dear colleagues. Welcome to the 5th Annual OncoAlert Colloquium, a comprehensive review of the year's top scientific advancements organized by Tumor Group. The colloquium is made possible thanks to our partners at the European Society of Gynecological Oncology, the European Society of Surgical Oncology, the Multidisciplinary Association of Supportive Care in Cancer, and the International Society of Geriatric Oncology. We're also grateful for the tremendous collaboration from the Advanced Prostate Cancer Consensus Conference, ABC Global Alliance in Breast Cancer, the Belgian Society of Medical Oncology, KidneyCan, the GARD Consortium, and our friends at GUcast. We would like to thank Pfizer and Roche for partly sponsoring this year's colloquium, and we would like to remind you that all presentations that you will see have been made independently by presenters with no industry influence on topics or content. The colloquium is divided into 7 days. Day 1, GU Oncology. Day 2, Lung Cancer and Supportive Care. Day 3, Breast Cancer. Day 4, GI Oncology. Day 5, Gynecological Cancers. Day 6, Hematology, Sarcoma, Lymphoma, and Geriatric Oncology. And Day 7, How I Treat Cancer When Facing Limited Resources. Today we start off with breast oncology, and a pleasure to introduce today's speakers. Dr. Erica Hamilton of Sarah Cannon Cancer Center, Dr. Stephanie Graf of Brown University, Dr. Hope Rugo of the University of California, San Francisco, Dr. Evandro D'Azambuja of the Belgian Society of Medical Oncology, Dr. Kevin Puny of the Belgian Society of Medical Oncology, Dr. Miriam Lusberg of Yale Cancer Center, Dr. Matteo Lambertini of the University of Geneva, Dr. Jose Boulders of the European Society of Surgical Oncology, Dr. Fatima Cardoso of the ABC Global Alliance, Dr. Roberto Salgado of AC Mittelheim, Dr. Iker Martini of the University of Florence, Ms. Christine Hodgson of GRASP, and Ms. Tanya Spanich of Europedona, Slovenia.
Hello, I'm Dr. Erica Hamilton, and I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. Happy to join OncoAlert and join the colloquium today. I'm going to be talking about advanced hormone receptor positive and HER2 negative breast cancer. These are my disclosures to say that we do a lot of clinical research, but I take no personal funds from pharma. So this is how I'm going to try to do a very quick whirlwind 15-minute tour. Efficacy of CDK after prior CDK, efficacy of new novel endocrine therapy backbones, CDK4/6 versus chemo as first-line treatment for hormone receptor-positive metastatic disease, and try to put this one to rest once and for all, and then talk about some of our new ADCs in the pipeline. So let's talk about CDK after CDK, and we had a very large confirmatory trial, the post-MONARCH trial, that read out in 2024, was a late-breaking abstract at ASCO, and this was a phase 3 trial of fulvestrant with or without abemaciclib for hormone receptor positive metastatic breast cancer following for patients that had already received endocrine therapy and CDK4/6. So this was really kind of maintained as confirmatory trial, but you can see that these patients had a median duration of prior CDK at about 20 months, so pretty on point, what we would expect. And you can also see that the majority of patients had received prior palbo at about 60%, but there was a fair number of patients, about a third of patients, that had received prior ribociclib. This is what we saw in terms of abemaciclib fulvestrant. It gives us a PFS of 6 months. Fulvestrant with placebo gives us a PFS of 5.3 months. This was a hazard ratio of 0.73. It was statistically significant, but you can see that it was small in magnitude. When we look at blinded independent central review, what we see are the PFS are longer, a little bit longer in both arms, but kind of this gestalt that maybe we took patients off study a little bit earlier than really objective progression. So kind of maybe more earlier than otherwise. And so what we see is that the PFS has lengthened 12.9 months with abemaciclib versus 5.6 with fulvestrant alone, a hazard ratio of 0.55. And if we look at this, our delta between the arms certainly looks more encouraging at 7.3 months. When we look at subgroups, I think this is a very important question. What about those with or without visceral mets? What about those that didn't do very well on their prior CDK or did really well? Are they more likely to get benefit? And we saw, regardless of visceral disease, really kind of abemaciclib is performing a little bit better. And even when we look at CDK less than 12 months, we still see a benefit of going to that abemaciclib. So I think that's reassuring. And over on the right, you see if you had done better on CDK for 12 months or greater, our PFS are a little bit longer, which I think is also reassuring, 5.4 versus 7 months. So you can see, regardless of ESR1, regardless of alterations in PI3, AKT, or PTEN, we still see this benefit. So there isn't a certain population that we shouldn't think about this for, although it does make it a little bit trickier that we do have some targeted drugs as well. So I think this is really confirmatory data to support the use of abemaciclib after palbociclib and endocrine therapy. And I think about this particularly for my patients that have a bland mutation profile, so that I'm not thinking about elacestrant, I'm not thinking about targeting PI3, AKT, et cetera. We know that fulvestrant alone really is not giving us a good PFS of about 1.8 months. And so combining with abemaciclib certainly is attractive for those patients. What about our new endocrine therapy backbones? I think EMBER-3 was the most significant of the trials that we heard about in 2024. This was imlunestrant as either monotherapy or with abemaciclib. And so you can see we had imlunestrant in arm A, we had standard of care endocrine therapy, fulvestrant or exemestane in arm B, and then this bonus arm C where we looked at imlunestrant with abemaciclib. Note that in this study, we didn't have an arm that looked at fulvestrant with abemaciclib. So that is a little bit of a detraction here. About 900 patients randomized in a 1-to-1 fashion. You can see that ESR1 mutations in about a third of patients, PI3 alterations in about 40% of patients, and most patients had seen prior CDK. So when we look at PFS in all patients, imlunestrant versus standard of care, you can see that we did not see a difference. We saw a difference only in the subset that had ESR1 mutations. So very in line with what we see from elacestrant, that it's really our patients with ESR1 mutations that are benefiting from that single agent SERD. When we look down on the bottom, we see that data 3.8 versus 5.5 months. What about when we look at imlunestrant with abemaciclib compared to imlunestrant? We see a significant lengthening in PFS, at least by my opinion, 5.5 months up to 9.4 months. And this is statistically significant with a hazard ratio of 0.57. This is a 43% reduction in the risk of progression or deaths. You can see this broken out by ESR1 mutation or no ESR1 mutation, and this is regardless of ESR1 mutation. So we see, abemaciclib really being agnostic to that. So a lengthening with mutations 5.5 to 11.1 month, and without a more so bland profile 5.5 up to 9.1 months. The dreaded cross-trial comparisons, but we can't help ourselves. And Dr. Burstein presented this, and you can see that imlunestrant with abemaciclib with that 9 months PFS is really longer than we've seen in that second line setting where we're dealing with a lot of endocrine resistance. And to be quite honest, we're not very good at picking out who are those patients that are maybe going to have endocrine resistance. We can enrich by selecting for patients that have ESR1 mutations. We can enrich by patients that have done well on CDK for at least 12 or 18 months, but we're certainly not perfect at it. And I think this really is encouraging data looking at imlunestrant, so novel endocrine therapy with the combination of abemaciclib. And I think, just notable that this PFS is comparable to what we saw in ELAINE, ELECTRA, et cetera. So let's move on to CDK versus chemo. We've seen multiple trials about this, but we had some data from PADMA and also Right Choice, and I hope we're going to put this to rest now. So this was first line palbociclib with endocrine therapy versus chemotherapy for high risk hormone receptor positive metastatic disease. So no asymptomatic bone only patients, no oligometastatic disease. And so really kind of this higher burden visceral disease patients, should we maybe be giving a chemotherapy induction? And we see that that is not the case. So very confirmatory to what we've seen in other trials, that even for our patients with visceral high burden of disease, that endocrine therapy outperforms chemotherapy. So in the absence of true visceral crisis, there really isn't a reason to think about chemotherapy. Endocrine with CDK is enough. So you actually see that time to treatment failure being about 11.1 months longer with endocrine therapy and palbociclib here. Very reassuring data. Right choice. This was back in 2023, but just to kind of remind you, this was kind of aggressive disease. Again, physician's choice of doublet chemos or endocrine therapy with ribociclib. And we did see the same thing. So ribociclib endocrine therapy beating combination chemotherapy by almost 9 months. And I think, CDKs are not perfect, but I think we could all probably agree that our patients prefer to be on CDK4/6 inhibitors compared to combination chemotherapy, and in general have much less side effects. So I think this is very practice confirming. So data from multiple trials now we have with endocrine therapy CDK really demonstrates that this combination is superior to chemotherapy, even with patients with aggressive visceral disease. And all patients really should be treated with this combination in first line, likely. I think we are not very good at really teasing out who doesn't need CDK in the first line. And so this is at least my practice pattern. So let's move on to antibody drug conjugates. We had a couple of studies here, TROPION-Breast01 as well as DESTINY-Breast06 to add to the Destiny library of studies. So this was TROPION-Breast01. This is datopotamab deruxtecan, Dato-DXd. So we're talking about a TROP2 targeting antibody drug conjugate like sacituzumab, but we're now talking about this deruxtecan DXd payload like trastuzumab deruxtecan. So I love saying if trastuzumab deruxtecan and sacituzumab had a baby, it was Dato. So this was Dato versus a treatment of physician's choice for hormone receptor positive breast cancer. Patients had been previously treated with 1 to 2 lines of chemotherapy, and it was very simple. Dato-DXd randomized 1-to-1 fashion versus investigator's choice chemotherapy. It turned out that the median number of priors for patients was 3. Almost everyone, over 80%, had seen CDK4/6, and most of these patients, by the time they get to 1 to 2 prior lines of chemo and they've exhausted their endocrine therapy, they have visceral disease, so 3/4 of patients. We saw that Dato-DXd improved progression-free survival 4.9 up to 6.9 months. This was statistically significant. Safety profile of Dato did compare favorably. Patients that were receiving Dato had fewer grade 3 or greater events and fewer dose interruptions or reductions compared to patients on chemotherapy. We do not have approval for this in the United States, but we do have approval for this in Japan. So congrats to Japan for being the first one to the party here on December the 27th, 2024. So literally just a couple of weeks ago. Now let's move to DESTINY-Breast06, so trastuzumab deruxtecan. We're well familiar in our initial study with DB02, our DB03 study that really cemented this as a standard of care against TDM1. Then we had DB04 that expanded from HER2 positive down to HER2 low, and DB06 is asking 2 new questions. What about the patients that have IHCs of 0 but still have some staining? And what about first line chemotherapy, not waiting until patients had already progressed on a line of chemotherapy? So this is what we see here. They are chemotherapy naive. They had, you can see in prior lines of therapy, at least 2 lines of endocrine therapy with or without targeted therapy, or they could have 1 line if it was in combination with CDK4/6, and they progressed on that. So TDXD every 3 weeks versus treatment of physician's choice chemo. Our HER2 ultra low population, so again, not the 1+s and the 2+s, but the 0s that are still an IHC of 0 but do have some staining, was about 18%. About a third of our patients had primary endocrine resistance, about a third were de novo metastatic disease, and the median prior endocrine therapies was 2. So this is a real world hormone receptor positive patient that's exhausted their endocrine therapies and are going on to chemo, kind of what's best. We do see progression-free survival being longer with trastuzumab deruxtecan compared to treatment of physician's choice, 13.2 versus 8.1 months for a benefit of over 5 months. This was statistically significant, and this is the all-comers, HER2 low plus the ultra low. When we specifically look at our ultra low patients, so a lot of people have the question of, okay, well, a zero, I mean, is it really the low patients that are driving this? And in fact, we don't see this. So PFS among just the ultra low IHC zeros with some expression, 8.3 months up to 13.2 months for PFS. This is a 4.9 month benefit. And you can see overall survival, not statistically significant yet, but you certainly can see these lines and curves separating here. If you look at my red box table underneath our graphs, all the way to the right, you can see the overall response rate, certainly also much higher with TDXD, about 62% versus about a quarter of patients, 26%. So TDXD clearly improved efficacy in both HER2 low and HER2 low ultra low populations compared to chemotherapy. And so this does add data for us around using trastuzumab deruxtecan earlier and for those with less expression. I think the question is, capecitabine is a good drug for hormone receptor positive disease. I don't know that this is going to universally be used for everyone. I think it's a really good option for our patients that we really know do have aggressive disease and that you really need a response for. So adds another option to our arsenal for sure. We also saw a little bit of data, Icarus Breast01, patritumab deruxtecan in second line. And so what's interesting about this trial was specifically these patients had not seen prior ADCs here, no prior TDXD. So second line HR positive disease, progression on at least one prior chemotherapy, exhausted their endocrine therapies. And what we saw was some fantastic responses over on the left and a PFS of 9.4 months. So this really just kind of continues to show us that ADCs have great activity. Sequencing is going to be a challenge. We definitely do see less activity for one ADC after another, whether we're talking about target or whether we're talking about payload. We're really going to have to figure out how best to sequence and figure out who has resistance. So Dr. Burstein presented this at San Antonio in his discussion. I thought it was a great slide. Suggested treatment algorithm for HR positive disease. You can see that there's a lot of things about genomics that are really significant here. Whether we have wild type, whether our patient has an ESR1, whether our patient has a PI3 alteration. And then you can see below the hash line on the bottom, we're really talking about patients that had AI and progressed. And so their first line combo is a fulvestrant-based combo, but the rest of that graph looks very similar. So key takeaways, endocrine therapy with CDK4/6 is the preferred first-line treatment for HR positive, HER2 negative metastatic disease, and chemotherapy really should not be given instead of CDK4/6, just instead of visceral disease. Switching a CDK4/6 after progression, specifically to abemaciclib, is certainly a reasonable option. Our novel SERDs are looking to be more effective and, for the large part, more tolerable than standard of care endocrine therapy, and likely will replace them as combination partners in the second line setting. Certainly, evaluations underway in first line as well as an adjuvant setting for these novel oral SERDs. Trastuzumab deruxtecan certainly could now be a first-line cytotoxic option for hormone receptor positive patients that have exhausted their endocrine therapies for their tumors. And it's also effective in a HER2 ultra-low patient population of an IHC 0 with some staining. And I think our biggest unmet need here is really around ADC sequencing, and we need biomarkers to target appropriate patient populations. So Whirlwind Tour, happy 2025. Hope it is a great year for all of you. Thank you.
Hello, I'm Dr. Stephanie Graf, Director of Breast Oncology and Associate Professor at Brown University, and I'm honored to be presenting on behalf of the OncoAlert Colloquium today, HER2-positive metastatic breast cancer. Thank you for joining us. Today, I'm going to review the current landscape of HER2-positive metastatic breast cancer, updates from the Breast family of clinical trials, 01, 03, 02, and again, an update from 03, Destiny Breast 12, and other new key data on brain metastasis in HER2-positive metastatic breast cancer, and finally, the AFT38 PATINA trial. So the current landscape of HER2-positive metastatic breast cancer is beautifully outlined in an ASCO education book chapter with first author Dr. Corti. Shout out to her. Also to ASCO book editor Nate Pinnell. Just a lovely review titled Systemic Therapy in Breast Cancer. This algorithm looking at first line through fifth line therapy for the management of HER2-positive metastatic breast cancer outlines that first line therapy starts with taxane-based chemotherapy plus trastuzumab and pertuzumab, followed by TDXD, tucatinib, capecitabine, trastuzumab versus TDM1, and the numerous different available options in the fifth line setting. There is an outline there calling out patients with active CNS involvement where tucatinib, capecitabine, trastuzumab may be a reasonable earlier line option in that setting based on results showing high efficacy of tucatinib in patients with active HER2-positive brain mets. And that really outlined where we were starting the year in early 2024. And so let's take a look at some of the updates we got out of the Destiny family of trials. Starting with Destiny Breast 01, in Annals of Oncology in March of 2024, Dr. Sara published an update giving us an update at 26.5 months of median follow-up. Of course, Destiny Breast 01 is a phase 2 single-arm trial looking at TDXD in HER2-positive metastatic breast cancer patients previously treated with TDM1. The primary result reported at 11.1 months, so this is a substantial update. Objective response rate showed 62.0% of patients had an objective response. Median overall survival, 29.1 months. Median progression-free survival, 19.4 months. And the adjudicated rate of drug-related interstitial lung disease occurred in 15.8% of patients, which unfortunately did include 2.7% of patients with grade 5 or fatal ILD. Destiny Breast 03 provided an update in ESMO Open in May of 2024, published by Dr. Sarah Hurwitz. DB03, as you know, is a randomized multi-center open label phase 3 trial of trastuzumab deruxtecan versus TDM1 in patients with HER2-positive metastatic breast cancer previously treated with trastuzumab plus a taxane. This update looked at an exploratory efficacy data in patients with and without brain metastasis at baseline. And it's really our first glimpse into the efficacy data for TDXD in patients with brain metastasis. In this analysis, we saw that patients with brain metastasis, the median progression-free survival was 15 months with TDXD compared to only 3 months in patients treated with TDM1 with a hazard ratio of 0.25. The intracranial objective response rate was 65.7% with TDXD compared to 34.3% in patients with TDM1. In Destiny Breast 02, an update was published in May of 2024 in Lancet Oncology. Of course, as you know, again, Destiny Breast 02 is patients with HER2-positive metastatic breast cancer randomized to TDXD versus treatment of physician's choice and has previously demonstrated superior progression-free survival and overall survival. And this updates the patient-reported outcomes. This update showed us that the baseline global health status was similar between TDXD and treatment of physician's choice, and it remains stable with no clinically meaningful change over time. The median time to definitive deterioration was delayed with TDXD compared to treatment of physician's choice for global health status at 14.1 months versus 5.9 months, and all other pre-specified PROs. Patient hospitalization rates were similar with TDXD and treatment of physician's choice. However, the median time to hospitalization was longer with TDXD at 133 days compared to 83 days for treatment of physician's choice. Simply, the PROs favored TDXD, which continues the story of the utilization of TDXD in HER2-positive metastatic breast cancer. Additionally, an update in Nature Medicine in August of 2024 by Javier Cortez on Destiny Breast 03, our second Destiny Breast 03 update of the year, showed that TDXD efficacy analysis at a median follow-up of 41 months from the primary analysis reported at 28 months. This update showed the median progression-free survival at 29.0 months compared to 7.2 months for TDXD as compared to TDM1. PFS improved from 12.4 months with TDM1 to 45.7% for TDXD, and median overall survival of 52.6 months for TDXD compared to 42.7 months for TDM1, with no new instances of grade 3 interstitial lung disease or overall survival, pneumonitis on adjudication, which is critically important. So updates for HER2-positive brain metastasis from Destiny Breast 12 and other data. In Annals of Oncology, Dr. Fabrice André presented this pooled analysis looking across the Destiny Breast family of trials using data from Destiny Breast 01, 02, and 03. The comparator arm included Destiny Breast 02 and Destiny Breast 03, so including both TDM1 and treatment of physician's choice. There were 148 patients in the TDXD arm and 83 patients in the comparator arm. The rate of intracranial objective response in patients with treated and stable brain metastases treated with TDXD was 45.2%, and with untreated or active brain metastasis treated with TDXD was 45.5%. The CNS progression-free survival in patients with treated or stable brain metastasis was 12.3 months in that first Kaplan-Meier curve, compared to 8.7 months for patients treated with the comparator arm. And critically, the central nervous system progression-free survival in patients with untreated active brain metastasis was 8.5 months for TDXD versus 4.0 months for patients treated with the comparator, with a hazard ratio of 0.1919. Moving to Destiny Breast 12, Dr. Nancy Lin presented at ESMO in Barcelona in 2024. I'd like to acknowledge Dr. Lin for sharing her original slides for my presentation today. You can give her a shout out on social media with those handles there. In Destiny Breast 12, this is a non-randomized phase 4 trial that accrued patients with either baseline brain metastasis, which could either be stable or active, or patients with no baseline brain metastasis, and they were followed for numerous endpoints, all treated with TDXD. Baseline demographics across the group were similar. About 50% of the patients had received 1 prior line of therapy, and 40% of the patients had received 2 prior lines of therapy. 62% of the patients were also hormone receptor positive. Baseline in the group of patients that had baseline brain metastasis, the progression-free survival in any site of progression-free survival at 12 months was 61.6%. And that was stable across patients in the overall population with stable brain metastasis and with active brain metastasis, which is, again, a consistent benefit among patients treated with TDXD. When we look specifically at the progression-free survival of patients with the central nervous system progression-free survival among patients with baseline brain metastasis, we see that the 12-month CNS progression-free survival is 58.9 months, which was similar between patients with stable brain metastasis and active brain metastasis. And when we look at the central nervous system objective response rate, we see a high degree of response within the central nervous system, showing a high degree of penetration, reaction, response when treated with T-DXd. Key is that the overall survival in patients both with and without baseline brain metastasis was similar, with a 12-month overall survival in those who had a baseline brain metastasis of 90.3% and with no baseline brain metastasis of 90.6%, treated with trastuzumab deruxtecan. Adverse events was similar in both cohorts. However, patients with baseline brain metastasis did have, unfortunately, a 2.3% risk of grade 3 interstitial lung disease, although many of those events were reported as co-occurring with an opportunistic infection, which is worth noting. AFT38 or PATINA, Changing Directions, looks at patients who are co-positive with both HER2 positive and hormone receptor positive metastatic breast cancer. Again, I'd like to thank Dr. Otto Metzger for sharing his original slides for use during the presentation today. AFT PATINA was presented at San Antonio Breast Cancer Symposium. It is a trial looking at a randomized open label phase 3 to evaluate the efficacy and safety of palbociclib, an anti-HER2 therapy, endocrine therapy versus anti-HER2 therapy and endocrine therapy after induction treatment for hormone receptor positive, HER2 positive metastatic breast cancer. AFT38 study design, patients with HER2 positive, hormone receptor positive metastatic breast cancer with no prior treatment after 6 to 8 cycles of trastuzumab and or pertuzumab with taxane or vinorelbine were eligible after completion of the induction chemotherapy with no evidence of disease progression. So they could have stable disease, a complete response, or a partial response. A total of 518 patients were randomized 1-to-1 to either trastuzumab plus or minus pertuzumab and endocrine therapy alone, or the same in combination with palbociclib, and were monitored until disease progression. The cohort had a median age of 53, was 92% Caucasian or white, was largely female, and had a median of 6 cycles of induction therapy. The vast majority of the patients received pertuzumab at 96 to 97%, and the majority received an aromatase inhibitor as their type of endocrine therapy. 68% had a CR or PR as their best response to induction therapy. And the primary endpoint, progression-free survival as assessed by the investigator, showed a significant benefit to the addition of palbociclib, improving median progression-free survival from 29.1 months for anti-HER2 therapy and endocrine therapy alone to 44.3 months for the combination of palbociclib plus anti-HER2 therapy plus endocrine therapy, with a hazard ratio of 0.74 and a p-value of 0.0074. And this is, in my opinion, immediately practice-changing and ready for clinical use. Median follow-up on patients who are alive and disease-free, 52.6 months. PFS stratification by subgroup shows a benefit for all subgroups, including patients whose best response was stable disease, a CR or PR, who had no prior anti-HER2 therapy or who did, and the cohort as a whole. Adverse events were largely what you would expect with the addition of palbociclib. And so updating that landscape using Dr. Corti's beautiful ASCO education book manuscript, we can add in the consideration of adding palbociclib for patients who are candidates with co-positive disease and who are otherwise eligible for treatment with a CDK4/6 inhibitor, and for patients with known active brain metastasis, we can add in that T-DXd, I feel, is a equal consideration to tecotinib, given the overall strength of data building on the DESTINY-Breast12 results. However, tecotinib does continue to have overall survival data and remains an important tool in our toolkit as we treat HER2-positive metastatic breast cancer. And I would like, and it's important that we consider the different delivery mechanisms and adverse events and engage our patients in shared decision-making when choosing between the different options, as they, of course, have not been compared head-to-head. As always, thank you for the honor of being faculty in the OncoAlert Colloquium. I hope you stay around and listen to the other extraordinary lectures that are a part of the Colloquium in this year in review. Thank you.
Hello, I'm Hope Rugo, a breast medical oncologist at the University of California, San Francisco's Comprehensive Cancer Center. For this year in review for 2024, as part of the OncoAlert Colloquium for breast cancer, I'm going to review advanced triple-negative breast cancer. So I've broken up the new directions in metastatic TNBC for 2024 into what didn't work and some exciting new directions, as well as one practice-changing study. So what didn't work included adding inhibition of the PI3 kinase pathway to chemotherapy in metastatic triple-negative breast cancer, potentially due to less exposure because of toxicity from these agents or multiple resistance pathways in the metastatic setting. Another trial looked at homologous recombination defect as a way to predict specific chemotherapy benefit, chemotherapy agents that result in DNA damage. In this trial, primary tissue was tested, and HRD may change over the process of tumors becoming metastatic. Also, testing methodology is not standard, but it remains uncertain why this particular study wasn't positive, except for the fact that primary tissue was tested instead of metastatic tissue. We also saw the data from a trial looking at atezolizumab combined with chemotherapy in patients with early relapsing triple-negative breast cancer, a huge unmet need. That also failed to show a benefit from the addition of atezolizumab, potentially due to multiple resistance pathways, or because we've seen now a negative atezolizumab trial in the early stage triple-negative setting. Is it the type of checkpoint inhibitor that is less effective in this setting? In terms of positive trials and exciting new directions, we saw another TROP2 antibody drug conjugate in a phase 3 trial, sacituzumab tirumotecan or sac-TMT. We've seen interesting combinations of antibody drug conjugates and immunotherapy, novel bispecific antibodies that have generated a great deal of interest, and then a trial looking at somatic and germline mutations to drive selective treatment with a PARP inhibitor. The future is complex. We have a long way to go in the treatment of metastatic triple-negative breast cancer, but we do have some exciting new agents and trials that we'll review in this presentation. Much of what we've learned, however, is to rapidly move effective treatments into the high-risk early-stage setting so we can benefit our patients the most with our effective treatments before the development of multiple mechanisms of resistance and metastases to organs that are even more difficult to treat. So let's start with CAPItello 290. This phase 3 trial looked at the addition of capivasertib to paclitaxel compared to placebo paclitaxel as first-line treatment of patients with metastatic triple-negative breast cancer. The dual primary endpoints looked at overall survival in the overall intent to treat population, as well as in patients who had alterations in PIK3CA, AKT1, or PTEN. And then, of course, the key secondary endpoints included PFS and safety. If we look at the mutational profile of patients enrolled in this trial, almost 70% had no alteration, which of course impacted the power, although the trial randomized 812 patients. PIK3CA mutations were seen in 12 to 13%, but intriguingly, a mutation that's seen quite uncommonly in patients with HR-positive, HER2-negative disease is much more common in metastatic triple-negative disease. 11 to 13% of patients had loss of the tumor suppressor PTEN gene, which is intriguing and suggests that PTEN plays a greater role in triple-negative breast cancer than in HR-positive metastatic disease. As you can see, this patient population, I think, reflects what we see in the first-line setting with metastatic TNBC, about 40% with de novo metastatic disease. The patients, about 50% had received prior neoadjuvant or adjuvant therapy. And in terms of PD-L1 positivity, which is concordant with more chemotherapy responsiveness, this was seen in about 15%. So in the overall population, median overall survival was identical between patients who received capivasertib or placebo with their paclitaxel. And this was true in the subset of patients. Again, this represents a smaller percentage than we would like, about 30% in terms of powering. But, it's 124 versus 125 patients. Absolutely no difference in median overall survival at 20 months in both arms. Hazard ratio is about as close to 1 as we would normally see in a non-beneficial study. However, interestingly, progression-free survival and overall response numerically favored the combination therapy, both in the overall and in the altered population. And that data is shown here on the upper right-hand side. You can see that the median PFS is just a little bit longer, but the hazard ratio is 0.72, indicating that a lot of patients progressed early and then had an improved outcome further along in treatment. We've seen this in a number of trials where we treat resistant populations. And then in the altered population, there's a greater numeric difference. Again, smaller number of patients, about 250 overall, but going from 5.6 to 7.5 months. Again, a very nice hazard ratio of 0.7. Overall response also, as you can see here, was numerically better in patients who received capivasertib versus those who did not, both in the overall and altered population. In terms of the adverse events, as expected, diarrhea was the most frequent all-grade and grade 3 or greater adverse events, and discontinuation, dose reductions, and dose interruptions were higher with capivasertib. So the primary endpoint wasn't met. Why was this study done? There was very encouraging phase 2 data, as well as with both capivasertib and other AKT inhibitors. Another phase 3 trial with ipatasertib also failed to reach their endpoint. And the big question comes up, if you could identify patients who had the altered pathway, would intervention in the early but resistant stage be more effective? And it's hard to know because this is a smaller population and triple-negative breast cancer represents only about 15% of breast cancer overall. But I think it's an intriguing question about whether or not you could target this alteration most effectively earlier in the course of therapy, such as in the post-neoadjuvant setting with an effective agent. But that question remains to be answered, and it's unclear whether or not future studies will look at these agents in TNBC. Perhaps it'll be left for the next generation of PI3 kinase inhibitors. So what about using HRD to choose a platinum-based regimen versus paclitaxel? So this trial, the Triple B trial, looked at patients who had HRD, and that occurred in about 53 to 62% of patients, and then randomized patients to receive paclitaxel or carboplatin cyclophosphamide. And then there was an add-on group where you could receive bevacizumab, which was an earlier treatment, or atezolizumab that was an amendment in 2018. And then patients could cross over to the other agent after progression. What they showed was interesting. HRD did not predict relative benefit from the platinum-containing regimen, either with an add-on treatment or not. And perhaps that's because HRD, again, was measured in the early stage setting, so primary tumor tissue rather than in metastatic tumor tissue. So no interaction, as you can see, p-value 0.1553. In the intent to treat in PD-L1 positive subgroup, atezolizumab improved PFS when added to paclitaxel with a hazard ratio of 0.5, but it didn't have any effect in the patients receiving carboplatin and cyclophosphamide. And then when you looked at the subset of patients who had PD-L1 positive disease and received paclitaxel atezo, that hazard ratio compared to paclitaxel alone was 0.37, highly significant. Again, a subset analysis analysis. And paclitaxel with atezo was superior for PFS in patients who were treated with a taxane with a hazard ratio of 0.41. So it's interesting, and it suggests that the chemotherapy partner for a checkpoint inhibitor is important in terms of seeing the benefit of the checkpoint inhibitor in patients with metastatic triple-negative breast cancer. And then the last study we saw that showed disappointing results was Impassion 132. These were patients who had early relapsing TNBC, and almost 70% had a disease-free interval of less than 6 months. They were randomized to receive carbogem or capecitabine with or without atezolizumab. They all had PD-L1 positive disease. And most of the patients received carbogem, about 3/4. Absolutely no difference in median overall survival, a disappointing 11 versus 12 months, not significant, hazard ratio 0.93. The median follow-up was 10 months, and the progression-free survival was only about 4 months. So absolutely no difference here. So the early TNBC remains a formidable challenge. We want to optimize treatment before patients develop metastatic disease, but maybe there was a role for the choice of IO agent or chemotherapy here, given what we saw in the previous study where carbocyclophosphamide wasn't as good a partner as paclitaxel. Perhaps we could overcome this with antibody drug conjugates, and we'll see that data in just a moment. So first, we're going to talk about a new TROP2 ADC with a topoisomerase payload, a belotecan derivative, sacituzumab trumatecan or sac-TMT. This drug has a drug-to-antibody ratio of 7.4 and was studied in patients with previously treated metastatic triple-negative breast cancer in a phase 3 trial in China. 263 patients who'd received at least 2 or more prior chemotherapy regimens were randomized to receive sac-TMT every 2 weeks or physician's choice of chemotherapy with a standard menu, and 66% received eribulin, and the next most frequent drugs were gemcitabine and vinorelbine. The patients had received a median of 2 to 3 lines of prior chemotherapy. Almost 90% had visceral metastases. And as you can see, progression-free survival was markedly improved with sac-TMT versus chemotherapy, with a impressive hazard ratio 0.32, going from 2.5 to 6.7 months, highly significant. And overall survival at interim analysis also showed a significant improvement in overall survival, although the median overall survival with sac-TMT was not reached. It was 9.4 months for chemotherapy, with a hazard ratio 0.53, also significant. And importantly, the 12-month overall survival rate was almost 58% for sac-TMT and 35% for chemotherapy. In terms of toxicities, they looked at the treatment-related adverse events in 30% or more patients. So there are a lot of adverse events not being reported here. The most common was bone marrow suppression and stomatitis, so overlapping both sacituzumab govitecan and datopotamab deruxtecan, Dato-DXd, which causes more stomatitis, less bone marrow suppression, and sacituzumab, more bone marrow suppression and diarrhea. This is actually the most common reason for dose reductions and interruptions. The other toxicities were quite uncommon, but I think it is important to see that 9% of patients had grade 3 stomatitis, but there was no prophylaxis, and we know that we can prophylax for this. So an interesting drug, and it's now being studied in a number of settings, and I'll just highlight 2 in the metastatic setting. In HR-positive disease, sacituzumab trumatecan is given alone or with pembrolizumab compared to treatment of physician choice in the first-line chemotherapy metastatic setting. So these are patients who've developed resistance to endocrine therapy and all who'd received CDK4/6 inhibitors. Then Trophus 11, a new trial in 2025, is looking at PD-L1 negative untreated metastatic triple-negative breast cancer, so a combined positive score of less than 10, comparing sac-TMT alone to sac-TMT with pembrolizumab, and then treatment of physician choice. So multiple are in clinical trials. This is the third of 4 TROP2 ADCs that are either approved or are in phase 3 trials. Dato-DXd recently approved for HR-positive metastatic disease with prior endocrine therapy and chemo. There's a lot of variation in toxicity between these agents, as well as the schedule of administration and ongoing first-line trials that we'll talk about in a moment. The efficacy and optimal sequencing is unknown, and multiple trials are ongoing or starting. So there was interesting data presented at ESMO Breast Cancer in 2024, looking at a TROP2 ADC in combination with atezolizumab in PD-L1 positive untreated metastatic triple negative breast cancer. Really impressive response rate of almost 77% with 5 complete responses and a median progression-free survival of 12 months in this 30-patient trial. And it's very similar to what was seen in datopotamab deruxtecan with durvalumab in the Begonia trial in triple negative breast cancer. Here they didn't test for PD-L1 as an eligibility, and the benefit was regardless of PD-L1 positivity. So really intriguing, and this is being studied now in clinical trials. So this shows you 2 trials with sacituzumab govitecan in PD-L1 positive metastatic triple negative breast cancer, and then Dato-DXd in PD-L1 positive metastatic triple negative disease. Both are untreated, and as I mentioned earlier, sac-TMT is being tested in PD-L1 negative metastatic triple negative breast cancer with a checkpoint inhibitor. So we'll have a lot of data in this area in the near future. We also, mainly because T-DXd is approved for HER2-low triple negative breast cancer based on a small subset from DESTINY-Breast04, I thought I'd show you this data that we presented at ESMO Breast looking at a pooled analysis for grade 1 ILD rechallenge after recovery in 9 different studies. And what was impressive was that a third of the patients who were retreated received drug for greater than 6 months, and almost 18% for greater than 12 months. We saw no mortality with retreatment, and the highest grade toxicity with retreatment was grade 2, which recovered with steroids. So really important to be thinking about that in patients who have recovered from grade 1 ILD. Now, I mentioned that there were 2 exciting anti-PD-L1 or PD-1 anti-VEGF bispecific antibodies that have been tested in metastatic TNBC: ivonescimab, an anti-PD-1 VEGF bispecific, and BNT327, an anti-PD-L1 VEGF-A bispecific. Really interesting drugs. They were both tested in the first-line setting in metastatic triple-negative breast cancer in combination with the taxane in phase 2 expansion studies. In the ivonescimab trial, you could have received paclitaxel or nab-paclitaxel. In the BNT327 trial, they just used nab-paclitaxel, and the standard doses were given. What's really impressive about this data are the overall response rates, which are quite similar in the 75 to 80% range, and that response as well as progression-free survival seems to be identical whether or not patients had PD-L1 positive or PD-L1 negative disease. And that's very exciting as well. Median progression-free survival was quite impressive in the trials ranging from 9 to over 10 months. So overall survival was also presented from the BNT327 trial, and this was also very encouraging. So based on this data, there's a lot of interest in studying these drugs in the first line and second line metastatic setting in combination with the taxane, and studies are being started this year. In terms of toxicity, the patients received taxane. They had neutropenia as their primary toxicity, as you can see here. Some liver enzyme elevations, but not much, and very few immune toxicities, if any, that were identified. And I think we need larger trials to understand the immune and anti-VEGF toxicities like hypertension, which they saw in some patients in both trials, but also to understand the impact of PD-L1 expression as well. Now, the trial I think that had the biggest impact on current treatment was olaparib expanded. This was a trial that was meant to solidify and confirm data from a smaller initial trial. And so they called them cohort 1A and cohort 2A of olaparib expanded, and included patients with germline PALB2 mutations and somatic mutations in BRCA1 and 2. And here you can see the numbers, and the number of patients with triple negative disease was 13 in both cohorts. Patients were treated with olaparib as their primary treatment and not randomized. Here you can see the complete response was amazing. I mean, they saw complete response in one patient in both arms, but the overall response, 75%, and then 37% for somatic BRCA mutations, both, I think, very impressive. And the median progression-free survival was 7.2 months for the somatic BRCA and 9.6 months for the germline PALB2. 2 out of 2 patients with triple-negative breast cancer and germline PALB2 responded, and 7 out of 10 patients with the somatic BRCA mutation, 70% response in patients who had triple-negative breast cancer. So I think that this is really important, no new toxicity signals, and should be a new standard treatment for patients in this setting. So a high overall response rate in both groups. I think 37% is very good as well. The overall incidence of somatic mutations is 13 to 14%. So I think this is something that can really benefit patients, and ctDNA is an excellent screening tool. They looked at the low variant, so the median variant fraction, and even patients with low variant allele fraction responded. There was no association with response. So what's practice changing in 2024? There's sufficient data, I think, to use olaparib for patients with somatic BRCA and germline PALB2 mutations. There were no other true practice-changing trials for metastatic TNBC last year, but there's a lot of potential. Moving ADCs into the first-line metastatic setting, we expect the first trials to report at ASCO 2025. We're looking at combinations with immunotherapy, and I think the bispecific antibodies are very exciting. This shows you 2 trials where we're expecting results potentially as early as ASCO 2025, ASCENT-03 with sacituzumab versus treatment of physician choice, and TROPION-Breast02, same design with Dato-DXd as first-line treatment for PD-L1 negative triple-negative breast cancer. With that, I'll thank you very much and look forward to our discussion.
Dear all, my name is Wanda Zambuja, a medical oncologist from the Julius Bordet Institute of Brussels in Belgium, and it's my pleasure to be here for this OncoAlert colloquy to discuss the year in review 2024, and I'm going to be talking about HER2-positive early breast cancer. These are my disclosure. I selected 5 topics that we could discuss. One is a new ADC showing promising results in pathological complete response, then the use of palbociclib, letrozole, pertuzumab, trastuzumab in elderly population, whether you can use imaging to predict the PCR in patients receiving neoadjuvant treatment, the neoadjuvant use of margetuximab, and the addition of pembrolizumab to paclitaxel, pertuzumab, trastuzumab. Starting with the FASCINATE trial is a third-generation anti-HER2 drugs. This molecule SHRA1811 is a new ADC, a new generation ADC composed by trastuzumab, a cleavable linker, and a topoisomerase I inhibitor as a payload. It showed promising results in phase 1 trials with their HER2-positive population showing a response of 76% with a safety profile. In this trial, patients were randomized 1:1:1 to receive either this new ADC alone, or the ADC plus pirotoniib at tyrosine kinase inhibitors, or pertuzumab, trastuzumab, carboplatin, and paclitaxel standard chemotherapy. Total duration 24 weeks, then they would go to surgery, and the primary endpoint is PCR. In this trial, 55% were hormone receptor negative, 90% node positive, 70% stage 3 disease, so a very advanced patient population. What was interesting is that the use of the ADC alone showed a 63% pathological complete response. When you use the ADC plus pirotoniib, 62.5%, and when you use chemotherapy, multiple chemotherapy, and pertuzumab, trastuzumab, 64%. And if you look on the right, the breakdown according to hormone receptor positive or negative. So the hormone receptor negative, the left columns, you can see between 71 to 76% pathological complete response, and the hormone receptor positive between 44 and 54%. So pathological complete response is similar with ADC pirotoniib, or chemotherapy, pertuzumab, trastuzumab. But what was interesting to see that in the arm with pirotoniib, they had much more toxicity, more grade 3 and 4, more discontinuation, dose reduction 70%, in more discontinuation 29%. The ADC alone, it was quite safe. It was similar to chemotherapy, much less discontinuation, is less dose reduction. So this is a promising approach. The addition of pirotoniib did not increase pathological response, but increased toxicity. So ADC should be compared with the chemotherapy standard of care. The TOUCH trial is a trial for postmenopausal patient, hormone receptor positive, HER2 positive early breast cancer setting, tumor greater than 1 centimeter or any 0, any 1. Those patients, they were randomized to receive paclitaxel, pertuzumab, trastuzumab for 4 cycles, or palbociclib, letrozole, pertuzumab, trastuzumab for 5 cycles without any chemotherapy. Then they would go to surgery. The primary endpoint was PCR. The hypothesis here is that the authors had a RB signature. If the signature was considered low, the hypothesis was that palbociclib letrozole would be better. But if the RB signature was high, the paclitaxel, the chemotherapy would be better. So what they found, they included here patients older than 65 and geriatric G8 less than 14, which is a frail population, 24%, and G8 greater than 14, a more fit population, 45%, median tumor size 25 millimeters, anyone 25%, grade 3, 56%. And they found a similar pathologic complete response between chemotherapy, pertuzumab, trastuzumab, or palbociclib, letrozole, pertuzumab, trastuzumab, 33%. So they could not demonstrate, they looked in the high and the low signature, and they could see that in the low signature patients who received chemotherapy had 42% pathologic complete response. Those with a high signature, palbociclib with letrozole and anti-HER2 drugs, 38%. So the trial could not demonstrate the primary hypothesis, but it's interesting to see how a treatment without chemotherapy can lead to 33% pathologic complete response. We were waiting to survive outcomes of those patients. The next trial, the TRAIN3 trial, patients with stage 2 with 3 HER2 positive breast cancer. This trial uses the MRI and ultrasound. The idea is you give it 3 cycles of paclitaxel, carboplatin, pertuzumab, trastuzumab. You do MRI and ultrasound, and if you confirm the radiologic complete remission, it goes surgery directly. If not, 3 additional cycles, MRI, ultrasound. If you go radiologic complete remission, surgery. If not, continue to 9 cycles and then go to surgery. What is interesting, CT2 or T3 in 87% of the patients, not positive in 60% of the patients. But you can see here that the MRI could predict the PCR in the hormone receptor negative 87% accuracy and the hormone receptor positive 53%. And if you see more chemotherapy, you give more chance of pathologic complete response in the hormone receptor negative up to 80%. And they show those 3 years event-free survival curves, and you can see for hormone receptor positive blue line, hormone receptor negative the orange line. There is no difference, very similar outcome in event-free survival and overall survival. So the primary endpoint was met in the hormone receptor positive and the hormone receptor negative population. And what we will look in those tables here on the right-hand side and the lower part, if you give 1 to 3 cycles, you have an event-free survival in hormone receptor negative 96. More cycles of chemotherapy, you can reach more pathologic complete response, but the event-free survival is lower. It's very interesting to see, to understand why is that. You see the same thing in the hormone receptor positive. The next trial, the PERGAIN trial that was already presented, the primary endpoint and the survival outcomes, and it was published in the Lancet 2024. This trial is a very pragmatic trial. Patients who were candidates for neoadjuvant chemotherapy, they had a PET scan, an MRI, and they were randomized 1 to 4 to receive paclitaxel, taxane, carboplatin, pertuzumab, trastuzumab, or pertuzumab, trastuzumab without chemo, but with endocrine therapy if hormone receptor positive. After 2 cycles, 6 weeks, they would do a new PET scan. If the PET scan in the group without chemo show a response, they would continue with anti-HER2 drugs without chemo. They would go to surgery. If the patient had a pathologic complete response, they would continue pertuzumab, trastuzumab to complete 1 year. So this arm B, one part did not have any chemotherapy. What they found that the pathologic complete response was better with chemotherapy, 57 versus 34, that was already published. But if you look according to the better response, those with better response, even without the chemotherapy, they had almost 38% pathologic complete response, those with chemo 65. And then if you see this group of patients without any chemotherapy at 3 years, they have a very good invasive disease-free survival at 94.8. The MARGO trial tested a new approach, 171 patients randomized 2-to-1, stage 2 or 3 early HER2-positive breast cancer. And here they tested for the CD16A genotype FF or FV. The idea behind this, the margetuximab would be an anti-HER2 antibody with a modified FC portion engineered to increase ADCC. This drug already showed some results in the metastatic setting. Here they tested in the neoadjuvant setting. 117 patients randomized to receive paclitaxel margetuximab pertuzumab and 54 to receive paclitaxel trastuzumab pertuzumab standard neoadjuvant chemo. The median age was 53 years, the tumors in 81%, node negative disease 65, stage 2 85%, hormone receptor positive 65. And the split in the genotype FF or FV are about half and half. So the trial could not show a numerically high pathologic complete response with margetuximab, a difference of 10%, but it's not statistically significant. So the trial is negative. They also looked according to the CD16A genotype, and there was no difference, only numerical difference. But there were more allergic reaction, infusion reactions with margetuximab. And the last trial I want to talk, the very interesting trial presented in San Antonio 2024. Patients who were candidates for neoadjuvant chemotherapy, they were randomized to receive three treatment arms. Arm A, paclitaxel pertuzumab trastuzumab, first 4 cycles. Arm B, the same chemotherapy and anti-HER2 drugs with pembrolizumab. Or the arm C, paclitaxel without paclitaxel, but pertuzumab trastuzumab and pembrolizumab. The arm C without chemotherapy was stopped early after 22 patients have been included, so with smaller patient population. What they included here, T1 tumor in 81 to 84%, node negative 6 to 68%, hormone receptor positive about 62%. And indeed they found if you give pembrolizumab on top of paclitaxel, pertuzumab, trastuzumab, you increase the pathologic complete response from 48 to 67. And then if you look at different definition of PCR, you can see an increase in this. If you look IPT 0 inside, you can see from 50 to 68. So you can see that it improves pathologic complete response. You should wait the results on the survival outcomes of this patient, but it is a promising approach to test. They also looked in terms of efficacy. The addition of pembrolizumab led to side effects that you know with immune checkpoint inhibitors, but there is no much worse than chemotherapy. So practice change in 2024. They are too early to say that they are practice change, but they are promising results with palbociclib, letrozole, pertuzumab, trastuzumab in the chemotherapy sparing approach in the elderly population. The Ferrier, the TRAIN-3 trial showed that we can use imaging to de-escalate neoadjuvant therapies. The NEO-HIP showed that the addition of pembrolizumab to paclitaxel, pertuzumab, trastuzumab increased pathological complete response. You need to wait survival outcome, but it's a promising results. In the FASCINATE-3 trial showed that a third generation HER2 drugs, ADC, has similar results to chemotherapy, another approach to be tested. And what is coming for 2025, we are waiting results of the DESTINY-Breast11, that patients in the neoadjuvant setting, 927 patients, randomized to receive TDXD alone, trastuzumab deruxtecan, or TDXD pertuzumab trastuzumab, or classical chemotherapy, anthracycline and cyclophosphamide pertuzumab trastuzumab. We are waiting results in those patients with residual disease after neoadjuvant chemotherapy. The DESTINY-Breast05, 1,600 patients randomized to compare TDM1, the standard of care, versus trastuzumab deruxtecan, the new agent. So we're eagerly waiting results, the head-to-head comparison. And the Stefania trial look for also for 1,700 patients with residual disease T-DM1 plus atezolizumab or T-DM1 plus placebo. So again, eagerly wait the results. With this, I would like to thank you for your attention.
Dear colleagues and friends, my name is Kevin Puny. I'm a breast medical oncologist working at the Ziekenhuis aan de Stroom in Antwerp, Belgium, and it's really my honor to be your speaker for the Year in Review 2024, focusing on early triple-negative breast cancer for this year's OncoAlert Colloquium. On this slide, you can see my disclosures. So looking back to 2024, main news still was related to the immune checkpoint inhibition in early TNBC. So we saw OS and biomarker analysis from 522. We saw 3 other phase 3 studies with other checkpoint inhibitors in either the neoadjuvant and adjuvant or the pure adjuvant setting. And then we saw an interesting real-world data analysis on PCR with chemoimmunotherapy in ER-low positive HER2-negative breast cancer. Next are ADCs, clearly ready to enter the scene in early TNBC with data for the TROP2 targeting ADCs, datopotamab deruxtecan with or without durvalumab in I-SPY 2, and sacituzumab govitecan single agent published in 2024 NeoStar data. And then to close, updates on PARP inhibitors will focus on the long-term survival analysis from adjuvant olaparib in Olympia, and will show the data from the ZEST study, both presented at San Antonio 2024. To start with, OS data from 522, very important data release, of course. We know the 522 study designed by now neoadjuvant and adjuvant pembrolizumab with a sequential carboplatin-containing anthracycline 3-weekly chemotherapy backbone with 9 cycles of pembrolizumab or placebo in the adjuvant treatment phase without additional systemic therapy. The updated event-free survival analysis shows that there is a small increase in absolute event-free survival benefit with a numerical difference of 9% at 5 years follow-up. The hazard ratio remains stable with a relative improvement of 35%. When we put this into perspective of the Delta PCR, we have to remind that the Delta PCR at the per protocol powered analysis at interim analysis 1 was 13.6%, but in the full trial population, Delta PCR was 7.5%. So again, the Delta EFS outperforms the Delta PCR, again underlying the fact that PCR is not an optimal measure of IO benefit in early TNBC. The OS analysis was very encouraging to see that there was almost a one-on-one translation of the relative benefit. The hazard ratio for OS was 0.66, statistically significant, and in absolute terms, this translates into 5 up to 7% less overall survival events. So again, after we saw something similar happening in HER2-positive breast cancer with adjuvant T-DM1 and residual disease from Catherine study, also now for stage 2-3 TNBC, it turns out to be that event-free survival is a valid surrogate endpoint for overall survival. Regarding subgroup analysis, it was confirmed that neither the nodal status nor the tumor size nor the PD-L1 status are driving the benefit we achieve with pembrolizumab. At the right of the slide, we see the outcome analysis according to whether or not achieve a PCR. Again, it's confirmed that achieving a PCR is associated with a good prognosis, irrespective of whether or not this PCR was achieved with chemotherapy alone or with chemoimmunotherapy. But we have to take into account when interpreting this graph that we are not looking at randomized subgroups. So the fact that 7.5% more patients are ending up in the upper curve when you combine pembrolizumab is not really represented in this data presentation. And what we also see is that it's not only about those patients that achieve a PCR with the addition of pembrolizumab, but also when patients do not achieve a PCR, we see that there's a clear divergence of the curves and a clinically relevant improvement of overall survival also in patients with residual disease. Regarding biomarker analysis, data was disappointing to many of us. Many had hoped to see data on stromal tumor-infiltrating lymphocytes, but this is not the case as till now. We have seen at San Antonio 2 biomarker analyses, one focusing on gene expression signatures and TNBC subtypes. So some gaps turned out to be prognostic for PCR and or for event-free survival, but this in both arms. But none of them were predictive for pembrolizumab benefit. And this was also the case for the 4 TNBC molecular subtypes. Only a higher tumor mutational burden turned out to be associated with an increased event-free survival in the pembrolizumab arm, but not in the placebo arm. So this is something interesting to dig further into, hopefully in the future. Another data analysis on biomarkers in 522 presented by Dr. Dent at San Antonio looked into the residual cancer burden and PD-L1 expression according to the CPS cutoff of 10. So patients with an RCB0 and RCB2 subgroups had lower likelihood of an OS event, but there were low numbers of events in some subgroups, and this was also the case in subgroups RCB1 and 3, hampering proper interpretation, in my opinion. The most pronounced OS benefit with pembrolizumab was observed in RCB2, while the difference was very small in RCB0. Looking into the benefit according to CPS cutoff 10, it was confirmed that a higher PD-L1 expression is associated with a better outcome, but this is a prognostic impact. This is irrespective of pembrolizumab, at least in relative terms. But because of the better prognosis of patients with a CPS of 10 or higher, irrespective of pembrolizumab, the absolute benefit achieved with the addition of pembrolizumab in 5 years OS was larger in patients with a CPS less than 10. Another checkpoint inhibitor evaluated and reported in 2024 at ASCO was the A-BRAVE study investigating purely adjuvant avelumab in patients with high-risk triple-negative breast cancer. The study had a co-primary endpoint of disease-free survival in both the ITT and in those patients presenting with residual disease after neoadjuvant chemotherapy, and the study failed to meet the co-primary endpoints. The delta at 3 years DFS of 5 and 6% were not statistically significant, while the secondary outcomes, OS, and the exploratory outcome, distant disease-free survival, showed a significant improvement with avelumab compared with observation alone, and a numerical benefit of 7.5 up to 8.5%. So, of course, the study did not meet the primary outcome, but taking into account the signals we see, avelumab might have a future role, potentially in the pure adjuvant setting in high-risk TNBC. Also, patients with the ER-low positive status were allowed in the study. But of course, for me, it's not enough. I think we need to put into perspective with the negative data from IMpassion030, a much larger study, a pure adjuvant setting with atezolizumab. So as for now, I don't think we can state that pure adjuvant IO is a recommended treatment approach and certainly not the preferred option. GEPARD-2 was a phase 3 study investigating the addition of atezolizumab or placebo to neoadjuvant chemotherapy and then continued in the adjuvant setting. In this study, patients were allowed to receive either capecitabine or olaparib when not having a PCR after surgery. So the primary outcome of GEPARD-2 was event-free survival, and there was no statistically significant improvement in EFS. At the median follow-up of 4 years, the absolute benefit was 3.3%, but not meeting the predefined thresholds. The PCR was significantly better with chemo-atezo compared to chemo-placebo, and the delta was 6.3%, quite mimicking actually what we see in ITT of 5 to 2, slightly lower than observed in the smaller phase 3 IMpassion031 study. But no impact on 4-year OS. The interaction test for atezo was positive for nodal status, but not for stromal TILs, and also not for the PD-L1 status. But I think we can conclude that after the NeoTrip, after IMpassion030, and now the GEPARD-2 results, the future of atezolizumab in early TNBC is unclear. Very short, another phase 3 study investigating camrelizumab, another checkpoint inhibitor in a Chinese placebo-controlled phase 3 study, CAMRELIEF, only powered for PCR, and the study was positive with a delta PCR of 12.2%. Follow-up for long-term outcomes is immature as for now, and unfortunately, the CAMRELIEF is not powered for long-term outcomes as was in IMpassion031. So it remains a question whether, based on the results of this study, camrelizumab plus chemotherapy will ever be a future treatment option for stage 2-3 triple-negative breast cancer. An interesting real-world data set from France reported on the PCR rates in 114 patients treated with the Keynote 522 regimen with a HER2-negative early breast cancer and an ER and/or PR low status of 1 to 9%. And we can see that actually the PCR achieved with the 522 regimen is very high, 75%. And of course, when we compare this to PCR achieved with chemoimmunotherapy in 522, but also with the PCRs observed in the ER low subsets of 756 and 7FL, we see that this is clearly encouraging and driving our clinical practice to consider the stage 2-3 ER low, PR low, HER2 negative breast cancer for the 522 regimen. Summary of IO in early TNBC, OS positive for Pembro, confirming 522 as standard of care for stage 2-3 triple negative breast cancer, and probably also for ER low positive HER2 negative breast cancer, but important ongoing searches to optimize the approach in patients with residual disease. Chemotherapy backbone, patient selection for chemo and immunotherapy with interesting de-escalation trials coming our way. And then last but not least, the Pembro treatment duration and those questions with de-escalation trials as optimized PCR and Pembro ongoing and planned. Next up, ADCs enter the scene in early TNBC. So let's start with data released from I-SPY2 on datopotamab deruxtecan with or without durvalumab in the neoadjuvant setting. Only 4 cycles of this TROP2 targeting ADC. And looking into PCR, we see that patients who had an immune positive molecular signature achieved PCR rates of 65%, meeting the thresholds for graduation in I-SPY2, but also, despite not formally meeting the threshold, the overall PCR rate in all triple negative breast cancer patients enrolled in I-SPY2 was very encouraging, at least considering that this is only a treatment duration of 12 weeks ADC IO. And then looking into the data only cohort, here we can see that none of the cohorts meted the graduation criteria, but also here we see PCRs for 12 weeks of ADC treatment only of around 30% in some of the subgroups, which is still encouraging, but certainly the combination results are encouraging and will be further evaluated in phase 3. So NeoStar study investigating 4 cycles SG in early TNBC, and here they saw an overall response rate of 30%. These data are earlier presented but published in Annals of Oncology over last year, here we can see that the TROP2 expression was not significantly different between patients presenting with residual disease or PCR, while the stromal TILs and Ki67 were significantly different. This slide provides an overview of the future of ADCs in early TNBC. A lot of very interesting studies ongoing with sacituzumab govitecan, datopotamab deruxtecan, but also a newer TROP2 targeting topo-1 payload ADC, sacituzumab timurotecan or sac-TMT. And in the neoadjuvant setting, this is a very interesting ongoing study which aims to actually eradicate all traditional chemotherapy out of the treatment regimen by administering 8 cycles datoturva in the experimental arm in the neoadjuvant setting. This approach is being evaluated in the ongoing phase 3 TROPION-Breast04 study. Very short PARP inhibitors, positive updates on Olympia. The 6 years IDFS benefit increased to an absolute delta of 9.4%, and also the OS rate increased, carryover effect difference of 4.4%. So confirming meaningful, consistent benefits from olaparib, and interestingly, in Olympia also a signal that there were fewer new primary malignancies in the olaparib arm and no evidence of increased risk of myelodysplasia or acute myeloid leukemia. And then the ZEST study investigating whether or not an MRD-guided therapy based on ctDNA positivity during follow-up in plasma was feasible, and whether there was any clinical utility from, but the study needed to be discontinued, but because not many patients presented with ctDNA positivity, and most patients that did were already stage 4 at staging with macroscopic metastasis. So at the moment, using ctDNA to guide therapy is not ready for standard practice. Early TNBC in 2024, to summarize, was the year of practice confirming rather than practice changing data. 2024 also informed us what is not fit for current practice. So adjuvant-only checkpoint inhibition, atezolizumab, camrelizumab, but also dual checkpoint inhibition from phase 2 Bellini and ctDNA-guided therapy decisions. But ADC treatment approaches in adjuvant and neoadjuvant TNBC have a very high potential to improve efficacy and also to mitigate at least some long-term chemo-related toxicities. Coming in 25, hopefully Saskia, maybe some early data release on Scarlet, investigating whether we truly need anthracycline in the chemotherapy backbone. But of course, we anticipate more data on predictive biomarkers for both chemo and IO benefit, TILs, TNBC-DX, hopefully dynamic biomarkers, and we anticipate results from ongoing pivotal phase 3 studies. And we encourage, of course, inclusion in both de-escalation and ADC-IO trials. With this, I really thank you very much for your attention, and I hope you have enjoyed the lecture and looking forward to further discussion on this topic.
Hello, this is Dr. Miriam Lusberg, and I will be giving you an update in the most recent developments in hormone receptor positive early stage breast cancer. My disclosures are here. So I've divided the talk into several key questions, starting with how to right-size therapy and avoid over and under treatment in early stage breast cancer. So in the last several decades, we've had several useful platforms for personalizing systemic therapy decisions, including Oncotype DX and MammaPrint in hormone receptor positive early stage breast cancers. And And as we can see here, the use of these genomic expression profiling has led to significant reduction in systemic chemotherapy use, reserving chemotherapy for the highest genomic risk tumors. One question that has continued to persist is in node-positive patients who are premenopausal. I will go back one more time to this study where what we saw in the responder study is that in patients with scores 25 and under who were postmenopausal, there was no benefit to the addition of systemic chemotherapy to traditional endocrine therapy, but we actually did see a difference in premenopausal women. And an ongoing debate in early stage breast cancer has been, is this difference in outcomes due to the ovarian suppressing effect of chemotherapy or indeed a true chemotherapy effect? So in the last year, there was additional efforts to help clarify these questions, including the exploratory analysis looking at anti-Müllerian hormone as a potential biomarker to see if we can better tease out the premenopausal women under age 55 who may have had lower ovarian reserve, more in the postmenopausal range. And it appeared that patients who had low AMH, there was no invasive disease-free survival benefit with chemotherapy, but those with higher ovarian reserve, then there was a benefit, again, suggesting kind of it's more hypothesis generating. This is not something that we're routinely using in clinical practice now, that patients are more likely to benefit from chemotherapy when they're truly premenopausal and the chemotherapy is causing that ovarian suppression. So generally, very intriguing data that were presented in the last year. But to truly answer this question of what is the true actual benefit of chemotherapy in premenopausal women, we have the offset study, which is slowly occurring right now. But this is going to be the more definitive study in terms of determining patients who are premenopausal and either have recurrence scores between 16 to 20 with high clinical risk, or recurrence scores with node-positive disease between 0 and 25, and they're stratified and randomized to receiving chemotherapy, subsequently followed by ovarian suppression and endocrine therapy versus ovarian suppression and endocrine therapy alone and CDK4/6 inhibitor allowed. It's a tough randomization for many patients to consider, so the trial accrual has been slow for now. And so part of the controversy, in addition to which premenopausal patients truly benefit from chemo, is the type of systemic therapy that we choose. And so we have had several analyses and interesting editorials. The Long Goodbye, for example, in anthracycline in early breast cancer by Drs. Grinda and Bernstein, really again suggesting how, as one of the oldest systemic therapy drugs, anthracyclines certainly have shown persistent efficacy over the years, but this has to be counterbalanced with long-term toxicities, including cardiac and myelodysplasia. And so we had the updated results of the compiled data from the ABC trials that were read out in the last year. And again, we're seeing that even though the non-inferiority of non-anthracycline regimens could not be fully shown in this analysis, really the biggest benefit appears to be in the hormone receptor negative group from anthracyclines and not the hormone positive group. And most interestingly, there was actually no significant difference in overall survival between the non-anthracycline containing and versus not, and 5-year survival rates were actually quite equivalent. So this may suggest that the slightly improved disease-free survival that we might be seeing with anthracyclines may be offset by late leukemias as well as cardiac toxicities. So in general, there's been a trend toward lower anthracycline use in hormone receptor positive early stage breast cancer, except that in the last San Antonio Breast Conference, we had a really intriguing presentation by Dr. Nan Chan and colleagues from University of Chicago analyzing the results of the Taylor RX studies, which prospectively showed the utility of using Oncotype DX testing to decide who gets chemotherapy. But in this analysis, what was looked at was the type of chemotherapy based on the recurrence score. So the investigators compared the 3rd generation regimen containing taxane and anthracycline with a non-anthracycline regimen such as TC. And you can see the patient characteristics here with kind of a good balance of both postmenopausal and premenopausal women. The recurrence scores were fairly balanced between the two groups, although patients receiving the TC regimen tended to have lower recurrence scores, and about 42% of patients in the study actually received the dose-dense ACT regimen followed by the standard ACT regimen, and then we have patients who receive the TC regimen as well. So if we compare by raw numbers, a greater number of patients actually receive the TC regimen as opposed to the third generation anthracycline regimen. And the investigators did an analysis looking at the recurrence score cutoff of greater than equal 31. And what they saw was that at this recurrence score, this was actually a differentiator in terms of which patients appeared to benefit most from a 3rd generation chemo regimen. Those tumors with the higher recurrence scores tended to benefit more from the anthracycline containing regimen, whereas the tumors with the more favorable biology, actually, it didn't matter whether they received TC or TAC. The delta for these more biologically aggressive tumors was approximately 5%, and this was significant with an adjusted hazard ratio of 0.32. In terms of disease distant recurrence-free survival, this also was significantly different in tumors that were had the higher recurrence scores, with 5-year distant recurrence-free survival of 95% for TAC versus 89.8% for TC. There was no difference in overall survivals. Breaking down further by menopausal status, both premenopausal and postmenopausal patients appeared to benefit and differentiate in terms of benefit from the type of chemo regimen. However, the effects seemed to be greater in premenopausal women. By subgroup analysis, it did appear that really, regardless of age, menopausal status, tumor size, grade, patients appeared to be able to differentiate benefit in terms of the 3rd generation regimen versus TC, based on that Oncotype recurrence score of 31 or greater. And so it's certainly very intriguing data, because for a long time we have said that the recurrence score is not a true determinant of whether patient should receive a certain type of chemotherapy for another, but for the first time, I think this is kind of challenging that paradigm. So kind of the key takeaways from the question one that I presented is that the latest trends are really focused on understanding the biological characteristics of breast tumor and kind of making decisions based on biology about whether to de-escalate or escalate systemic therapy. And the ongoing debate on the benefit of chemotherapy in premenopausal women with low genomic risk is still not quite settled, and this is something that we continue to grapple with in our routine practice. Question 2. Are there targetable pathways beyond hormone receptor status that can improve outcomes and tolerability of systemic therapy on hormone receptor positive breast cancer? And the intriguing results of the TBCRC 056 were presented this year in San Antonio by Dr. Erica Mayer. The study from the Translational Breast Cancer Consortium was reporting out on Arm C, which included patients with hormone receptor positive breast cancer receiving combination PARP inhibitor plus PD-1 monoclonal antibody therapy. And this was a preoperative approach, and the trial objective was to evaluate pathologic complete rates with this preoperative combination regimen, as well as assess changes in stromal tumor infiltrating lymphocytes. In general, we know that hormone receptor positive breast tumors tend to be less likely to achieve a complete pathologic response, and in this population of patients who have germline BRCA alterations treated with such an approach, the patients, about 44% of patients achieved an RCB of 0 to 1. The absolute pathologic rate was 16.7%. And there was overall the grade 3 events were more likely to be related to the immunotherapy and PARP inhibitor combination with rash, LFT abnormalities, and nausea. The correlatives of the study are most interesting, showing that higher tumor infiltrating lymphocytes were actually associated with a higher chance of PCR, and so this raises the question of, again, kind of that biomarker selection for patients that may be able to get away with more of a targeted therapy approach. And so as additional cohorts of the study get read out and additional genomic profiling is underway, I think this will be important preliminary data for future design of larger studies. The Salty Valentine study was also reported out in this year's San Antonio Breast Conference, and this was taking patients with operable breast cancer that were at least 1 centimeter or larger, HER2 negative, hormone receptor positive, with at least a Ki-67 of 20% or greater, and they were randomized 2:1 to HER3 ADC, HER3 DXd versus HER3 DXd plus letrozole, or a standard multi-agent chemotherapy. The primary endpoints were rates of PCR. And as you can see here, the treatment toxicity across the different arms are listed. Overall, there were less grade 3 toxicities when the HER3 ADC was used either alone or in combination with endocrine therapy relative to chemotherapy, and there were less treatment reductions and interruptions in the HER3 DXd arms. No ILD cases were reported. So in terms of preliminary data from this study, the PCR rates were relatively comparable with this kind of newer targeted therapy approach, similar to what is seen with multi-agent chemotherapy. And there were interesting correlatives looking at kind of the biological activity of these tumors, and it really does kind of these potential role of the HER3 TDXD in a variety of breast tumors is continuing to be evaluated in the SALTI program. And so I think this was an important study, kind of challenging us with a newer preoperative pathway approach in hormone receptor positive breast cancer. I did in the last year, we had further updates on use of adjuvant CDK4/6 inhibitors, including updated results from the NATALEE trial, showing that there even after discontinuation of the drug after 3 years, we are truly beginning to see improvement in invasive disease-free survival, with the current delta being 4.9%. And we also had a 2024 update on monarchE patient population with a continued benefit in invasive disease-free survival being seen at 5 years. So this addition of CDK4/6 inhibitors in the adjuvant setting has been an important therapeutic aid for our patients with high-risk disease. And the table at the bottom of this slide is comparing the eligibility criteria for both NATALEE and monarchE, with the most significant difference being that higher risk node negative stage 2 tumors are potentially eligible for NATALEE. So I think key takeaways for question 2 are that several promising pathways, including BRCA and homologous repair defect and HER3, were presented in the San Antonio conference, and that we continue to have maturity of data for the two new approved CDK4/6 inhibitors in high-risk hormone receptor positive breast cancer. Moving on to key question 3 is how can we optimize quality of life and symptom management in early stage breast cancer? So we continue to see lots of unmet need in early stage breast cancer, with a range of toxicities experienced on endocrine therapy, targeted therapy, immunotherapy, and chemotherapy. It's illustrative to show that the over close to a third or more of patients in the monarchE and NATALEE trials actually had to discontinue their CDK4/6 inhibitors. And so I think kind of as we come together as clinicians taking care of patients with early stage breast cancer, it's really important for me to emphasize that the targeted therapies, particularly if patients are experiencing significant toxicity, it's important to consider dose reductions. We actually have published data showing that dose reductions, for example, with adjuvant abemaciclib, do not impact invasive disease-free survival. So for patients who are struggling, rather than discontinuing the drug, considering dose reductions is important. Additional targeted therapies are available now and in the horizon for vasomotor symptoms. These are targeting the neurokinin receptor pathways. So fezolinetant is currently approved for hot flashes, and then newer agents are also in development. We continue to work together on addressing various chemotherapy toxicities, which impact our patients from head to toe. Just wanted to reemphasize that we continue to have good maturity of data in terms of efficacy of scalp cooling, particularly for taxane regimens, based on this large Dutch cooling registry data. So this is an option that's important to be offered for patients starting chemotherapy. And then we are currently, there's a national study in the US looking at the efficacy of cryocompression, continuous compression versus the control arm of low cyclic compression as a preventative strategy for CIPN based on promising phase 2 studies. In this year's San Antonio, there was a readout of the Be-Well trial as well as its additional correlatives. This was a health education and 2-year telephone-based weight loss intervention studies for early stage breast cancer. It included both hormone receptor positive and triple negative breast cancer. And this was compared to health education alone. And different metabolic and inflammatory biomarkers were assessed, and the intervention group that had lost more weight and was coached actually had interesting patterns of reduced inflammatory biomarkers at 6 months. So again, hypothesis generating in terms of kind of the benefit of weight loss intervention in terms of metabolic biomarkers and insulin resistant, and additional work is ongoing in these areas. And so kind of symptom management is a key part of how we optimize care in early stage breast cancer. And I just wanted to reemphasize that dose reductions should be considered for targeted therapies when needed in early stage breast cancer. And then lastly, question number 4 is, are there better surveillance tests in early stage breast cancer for detecting early and late recurrence? We know that late recurrences do go up over time for both node negative as well as node positive breast cancer in early stage breast cancer, with some patients actually having late recurrences, sometimes several decades from the initial diagnosis. I have some summary of some of the ongoing reported studies showing that perhaps detecting minimal residual disease using circulating tumor DNA can be a newer strategy in terms of detecting these recurrences. And both Monarchy as well as several other studies have really shown that if we are able to detect ctDNA or patients acquire ctDNA at any time in their course of treatment, this is certainly a negative prognostic biomarker. What we still don't know is how to use these biomarkers as a predictive biomarker. How do we act on this information, and are we able to change the course of disease? This is one of our unanswered questions, and there are several studies that are looking at kind of these MRD guided escalation studies, and I have listed some of these for your review. And it's important to do the ctDNA testing in the context of a study, because there are also potential harms associated with testing, including potential increased toxicity of starting therapies earlier than needed, a lead time bias type of picture, as well as anxiety and a false reassurance, since our tests are not fully sensitive and specific yet. So the takeaway from question number 4 is that, yes, ctDNA has emerged as a promising prognostic biomarker in early stage breast cancer, but additional studies are ongoing in terms of determining its role as a predictive biomarker, and outside of trials generally, the collective breast research community really advises caution for doing these tests outside of the research setting. So in conclusion, there are lots of exciting developments in early stage breast cancer, both in therapeutics and supportive care. Gaps persist in multiple areas, including detection and management of late recurrences. And certainly progress is ongoing with clinical trials as well as partnerships with our patients. Thank you so much for your attention.
Dear colleagues, it's a great pleasure and honor to be part again of the OncoAlert Colloquium 2024. My name is Matteo Lambertini. I'm a medical oncologist and associate professor in medical oncology at the University of Genova, San Martino Hospital in Genova, Italy. And today it's a pleasure to discuss a topic which is highly relevant to our young patient with breast cancer, which is fertility preservation and pregnancy after breast cancer. In the first part of the presentation, I'm going to discuss the available strategies for fertility preservation in this setting, and in the second part, how to counsel women that want to have a pregnancy following completion of anti-cancer therapies. I'm going to start with the recent data from the San Antonio Breast Cancer Symposium 2024, showing the importance of this topic for our young patients with breast cancer. This is another piece of evidence on the top of a lot of other studies showing almost all of them the same percentages, that between 40 to 50% of the patients diagnosed with young women with breast cancer are interested in the topic of fertility and pregnancy. So it's something relevant for almost 1 out of 2 newly diagnosed young women with breast cancer. And also recent data in 2024 showing that over the years, this topic is being discussed more often with our patients. More women are being referred for fertility preservation, and also the acceptance rate is increasing. And as I will discuss later, all patients should be diagnosed irrespective of different factors, irrespective of the number of prior children or stage of the disease and so on. But what we see is that those women that are more likely to accept to undergo fertility preservation, so that are more interested into this subject, are younger women, are partner, childless, as well as those diagnosed with early stage disease, stage 1, stage 2 disease. Even though today we're going to focus more on fertility and pregnancy, the toxicity of anti-cancer therapies, and particularly chemotherapy on the ovaries, that will lead to premature ovarian insufficiency. The development of this toxicity is not only associated with infertility, so the impossibility to have a pregnancy later on, but this toxicity is also associated with a lot of other side effects that can have a major negative impact on the quality of life of our patient. One of them, for example, is sexual dysfunction or menopause-related symptoms like hot flashes, vasomotor symptoms, bone health, cardiovascular health, and so on. So it's important to discuss fertility and pregnancy, but also a more general concept of ovarian function preservation. And these survivorship issues are very important to be discussed also from more an oncology perspective, meaning that we see from different studies that if we do not properly counsel women at diagnosis, but also throughout the cancer care trajectory on this subject, we may have patients that may decide to receive a suboptimal treatment because of this fertility and pregnancy concern. Meaning women that, for example, will not accept to undergo chemotherapy, or that may decide to stop endocrine therapy before the standard duration based on the risk of recurrence. And receiving a suboptimal treatment has been shown by different studies to be associated with suboptimal outcomes. And so survivorship issues may translate into survival issues if they are not properly addressed. Moving now to the available strategies for fertility preservation, I'm going to start with 2 important statements from the ESMO guidelines on this subject. The first one is that we have to counsel all young patients diagnosed at reproductive age with a complete oncofertility counseling as early as possible after diagnosis. And this counseling, so this information on the risk of developing treatment-induced gonotoxicity, should be done irrespective of type and stage of the disease. So all women should, and also men, should be informed about this side effect. The second important point is that potentially all systemic therapies may be associated with the risk of treatment-induced gonotoxicity. Our main task as oncologists in this counseling is to clearly disclose this risk with our patient without over or underestimating this risk. With chemotherapy, in the case of breast cancer, it's quite straightforward, the counseling. We know that it's strongly dependent by the age of the patient at the time of treatment, as well as the type and dose of chemotherapy that we are offering. Anthracycline taxane-based regimen in patients older than 40 years are associated with a very high risk of this toxicity. Same regimen in patients under the age of 30 years is associated with a very low risk, less than 20%, but probably even less than 10 or 5%. The main problem we have in this counseling nowadays is that we are not sure how to properly counsel those patients that are candidates to receive treatment other than chemotherapy. So targeted therapies, immunotherapy. We have some preclinical data showing the potential effect of these agents on gonadal function and ovarian reserve. But and then we have a couple of studies in mouse models showing that both the PARP inhibitor olaparib as well as immune checkpoint inhibitors may be gonadotoxic, may induce a depletion in ovarian reserve. However, the clinical data are very limited. Mostly, we have data with anti-HER2 therapies like trastuzumab or the TKI, lapatinib, or TDM1. So going back to the ESMO guidelines and looking at the flow of the oncofertility counseling, the main task that we have as oncologists, as already mentioned, is to discuss the first point, so to disclose with the patient the risk of developing treatment-induced gonotoxicity. And then the second task we have is to create a network with fertility specialists so that patients that wish to preserve fertility can be referred to fertility specialists for the second part of the counseling. So discussing the different cryopreservation option, oocyte embryo cryopreservation, or ovarian tissue cryopreservation, before offering GnRH agonists during chemotherapy. On the other side, patients that are not willing to preserve fertility, they are probably too old to preserve fertility, or they already have children, they are not interested in having children, but they do not want to develop early menopause, or they want to reduce the risk of developing early menopause. In this case, we can offer directly as oncologists the use of GnRH agonists during chemotherapy. Looking at the main efficacy and safety data with these three different options, starting with embryo oocyte cryopreservation, which is the first option, the standard strategy of fertility preservation to be offered. In terms of efficacy data, this is strongly dependent by the age of the patient. So the younger, the higher the chances of having a pregnancy. The pregnancy rate is between 30 to 40% in patients younger than 35 years. This success goes down in older patients, and in those women older than 40 years goes below 10%. And normally we do not refer patients older than 40 years to embryo oocyte cryopreservation. Recent data from the positive trial, I will discuss it later, the study that looked into the temporary interruption of endocrine therapy, has shown that undergoing oocyte embryo cryopreservation at diagnosis is associated with a significant increased likelihood of having a subsequent pregnancy later on. These data should be considered in the context of the trial. Patient had a very short window to try to get pregnant, so they were more likely to go back and use the cryopreserved materials. But these data are in the line that undergoing fertility preservation and diagnosis is indeed associated with increased chances of having a future pregnancy. In terms of safety data, we have now several studies showing that undergoing control ovarian stimulation at diagnosis, so before starting chemotherapy, is not associated with an increased risk of recurrence, so should be considered safe, also in the setting of hormone receptor positive breast cancer. In the case of breast cancer, and particularly hormone receptor positive disease, it's important to include letrozole as part of the stimulation protocols. If we include letrozole in the stimulation protocol, we see that there is no impact on the efficacy of the stimulation. So the number of oocytes being collected with stimulation protocol with or without letrozole is the same, but the level of estradiol during the stimulation are significantly lower if we include letrozole as part of the stimulation protocol. And here we see also from randomized data the same conclusion, no impact on the efficacy of the protocol, but much lower level of estradiol during the stimulation. In 2024, we have also had data on the safety of this option in BRCA carriers. Despite the small numbers, data reassuring, not showing any signal of potential increased risk of recurrence, also in the case of young women with breast cancer and carrying a germline pathogenic or likely pathogenic variants in the BRCA genes. Moving now to ovarian tissue cryopreservation, efficacy data. In terms of pregnancy and live birth rates, we see that they are very similar to oocyte embryo cryopreservation, 30 to 40% success rate. However, here the age is even more important. So the cutoff goes down from 40 years to 36 years. And the second important factor for the efficacy of this procedure is the expertise of the center performing the cryopreservation procedure, because cryopreserving ovarian tissue is more complicated than cryopreserving oocyte or embryos. So what the guidelines are advocating is to do the surgery in peripheral center, but then refer the tissue to centralized, more experienced center for the procedure of cryopreservation. This procedure should be considered only in patients that have no access or contraindication to oocyte embryo cryopreservation, so it's a second step procedure because it's a more surgical procedure. However, an advantage as compared to oocyte embryo cryopreservation is that when the tissue is being transplanted back, This does not only increase chances of having a future pregnancy, so it's not only a fertility preservation procedure, but this option restore also ovarian function in the majority of the cases. When the tissue is being transplanted, estrogen rises and FSH is being reduced, showing a restoration of ovarian function, and so also reduction of all the side effects of early menopause. Safety consideration, two main points. The first, not really relevant for breast cancer, the risk of malignant contamination to the ovaries, more a problem for hematological diseases or ovarian cancer. For breast cancer, the main issue is the risk of ovarian cancer in those women with hereditary cancer syndrome like BRCA carriers. At the time of diagnosis, very often we do not have the genetic testing results. But if we have these results, this option is not the optimal to be considered in BRCA carrier, but should be considered. We have very limited safety data in the setting of BRCA carriers. But in these cases, if there is a contraindication to oocyte embryo preservation, can be considered in women at a very young age, so several years before the recommended age of risk-reducing surgery, and then the transplantation procedure should follow special protocols. Finally, the last strategy is GnRH agonist during chemotherapy. This option has been studied by several randomized trials that were summarized in these individual patient level meta-analysis. In these randomized trials, premenopausal women with breast cancer were candidates to chemotherapy, were randomized to receive a GnRH agonist during chemotherapy or no additional treatment on the top of chemotherapy. Overall, if we use a GnRH agonist, we reduce by around 15% the absolute rate of premature ovarian insufficiency, so more than 60% reduced risk of developing these side effects. And this was the main goal of developing this strategy. So this is a strategy developed for reducing the risk of developing early menopause. We also have data on a significant increase in post-treatment pregnancies, a doubling in the number of pregnancies for those women that receive GnRH agonists during chemotherapy. But this strategy should not be considered per se a fertility preservation option, a replacement for oocyte embryo cryopreservation or ovarian tissue cryopreservation, but should be considered only after cryopreservation procedures or in those women that are not interested in fertility preservation, but are interested in ovarian function preservation. Safety consideration, we now are very much reassured that this option can be used in the setting of breast cancer, both in the case of ER-positive as well as ER-negative disease. Using concurrently GnRH agonists during chemotherapy does not impair the efficacy of chemotherapy, as for example we see with tamoxifen and chemotherapy. So in this case, we can use safely GnRH agonists during chemotherapy, also in the setting of ER-positive breast cancer. Moving now to the counseling of patients that want to have a pregnancy after breast cancer, very relevant topic because we see that breast cancer survivors have very low chances to have a future pregnancy as compared to women from the healthy general population. They have around 60% reduced chances to have a future pregnancy. One of the reasons is what we have discussed earlier on, so risk of premature ovarian insufficiency, lack of access to fertility preservation strategies. But another very important reason is that still many of us are concerned that a pregnancy after breast cancer may increase the risk of recurrence, being breast cancer a hormonally driven form of tumor. Between 30 to 40% of breast cancer oncologists are still concerned that the pregnancy may increase the risk of recurrence. However, this is a misconception because we do have now a lot of data summarized in this meta-analysis showing that having a pregnancy after proper treatment and follow-up for breast cancer should be considered safe. But I want to stress once more that after proper treatment and follow-up, and this proper treatment and follow-up can be different case by case based on risk of recurrence, age, and other factors. We do have data also in patients with ER-positive breast cancer that having a pregnancy following completion of treatment, including following completion of endocrine therapy, should be considered safe. Recently, we have had the presentation and publication of the data from the positive trial that has looked into the possibility to not wait for 5 years of endocrine therapy to have a pregnancy, but to have a break, a temporary interruption of endocrine therapy in those women with a strong pregnancy desire that completed already 18 to 30 months of endocrine therapy, allowing them to have a 2-year break, to have a washout after completion of endocrine therapy, try to get pregnant, carry the pregnancy, and trying to breastfeed later on before going back to endocrine therapy and complete the treatment. Very important academic prospective study that included more than 500 patients. At the first presentation, at a median follow-up of 41 months, the data are reassuring, as I will show in the next slides. But before going into the next slide, I think it's very important in our daily practice to look into the characteristics of those patients included in the study, being half of them with stage 1 disease and the other half with stage 2 disease, very small number of women with stage 3 disease. More than 1/3 received tamoxifen alone as endocrine therapy that we know we are giving to a population at low risk of disease recurrence. And more than 1/3 did not receive chemotherapy. So overall, at least half of the patient had a relatively low risk of disease recurrence. With this consideration in mind, the data reassuring, there is no apparent increased risk of recurrence if we compare the relapse rate in this study with a historical control from the SOFT-TEX trial with a similar patient population. What I'm not sure yet is the possibility to use this data in patients at high risk of recurrence, like those women with N2 disease. In the trial, 23 women were included, and still with a short follow-up, almost one out of 4 patients develop a disease recurrence. To me, this is not because of the pregnancy. I don't feel that the pregnancy is the trigger for the recurrence. Probably not even the temporary interruption of endocrine therapy, but to me, these are women with a very high risk of recurrence in the first 2 to 3 years, but also up to at least 5 years or more after diagnosis of breast cancer. And so this is why I would prefer to wait completion of endocrine therapy. Recently, the author have also published data on the factor associated with increased chances to have a pregnancy. Main factor is age. As expected, the younger the patient, the higher the likelihood to have a subsequent pregnancy. But as I've already discussed earlier on, also cryopreserving oocyte or embryos at the time of diagnosis is associated with an increased chance to have a future pregnancy. But I remind again that this setting is special because women had a quite short window to try to get pregnant spontaneously. In terms of how to apply this data in clinical practice, everything should start from the strong desire to become pregnant in a patient that is receiving adjuvant endocrine therapy. If the patient has a low risk of recurrence and she has age or ethical personal reason to not wait the completion of endocrine therapy, we now have safety data to temporarily stop the treatment to try to have a pregnancy. Those women that are very, very young, maybe they don't have the rush to have a pregnancy, will probably still go up to 5 years of endocrine therapy. In the case of high risk of recurrence, to me, it will be no, as I've already discussed. I think the data are not supporting the safety in a patient with a high risk of recurrence. However, we do have women that, despite our counseling, they really want to stop the treatment and get pregnant. In this case, I strongly advise to perform a restaging procedure before during the washout period of endocrine therapy. So before the patient starts the attempt to get pregnant, just to be sure not to have a bad surprise during the first trimester of pregnancy when non-systemic treatment can be offered and everything will be much more complicated. We now have data also in BRCA carriers that having a pregnancy after proper treatment and follow-up should be considered safe. These is a large series of young women with breast cancer, all of them with BRCA pathogenic or likely pathogenic variants. Safety on the baby side, there is no increased risk of malformation. However, in this pregnancy, there is an increased risk of cesarean section, low birth weight, preterm birth, small for gestational age, particularly for those women that have a pregnancy within 1 year after completing chemotherapy. And so the main message is that we need to monitor more closely these pregnancies and we should wait at least 1 year following chemotherapy completion. The timing of pregnancy after breast cancer, to me, the main point is the risk of recurrence of the patient and the age. So the younger, the more she can wait, the higher the risk of recurrence, the longer I will definitely wait. But then we have to consider also the washout period after completion of treatment that we should try to respect. Chemotherapy, as already discussed, 1 year is better to wait for 1 year. Monoclonal antibodies, anti-HER2 agents, 7 months. Tamoxifen, 3 months. and then a question mark on all the new treatment that are being used in the adjuvant setting or neoadjuvant setting. In 2024, we also had data on breastfeeding after breast cancer, 2 studies, one in the setting of ER-positive breast cancer from the positive study, and the other in the setting of young women with breast cancer and BRCA pathogenic or likely pathogenic variants, both of them showing that breastfeeding is feasible and safe in this setting. My conclusion, going back to the oncofertility counseling, as already shown by the ESMO guidelines, our task is to discuss gonotoxicity and to create the network with fertility specialists. Patients that are willing to preserve fertility, the first option is oocyte embryo cryopreservation if there are at least 2 weeks, 3 weeks of time available before starting treatment, which is the case in most of our patients with breast cancer. However, in those few cases in which there is a really urgent need to start treatment, we cannot wait 2 to 3 weeks, then we can refer the patient for ovarian tissue cryopreservation. And after cryopreservation procedure, we can offer GnRH agonists during chemotherapy. On the other side, patients that are not willing to preserve fertility, but they want to reduce the risk of premature ovarian insufficiency, then the use of GnRH agonists during chemotherapy should be offered. Second important conclusion, as an academic community, we really need to address the risk of gonotoxicity with the new anti-cancer treatment option. I think it's very important to advocate in clinical trials to collect some information that could be very critical to help the oncofertility counseling on our patients, so menstrual function after treatment, pregnancies after treatment, as well as, if possible, at least a couple of time points of anti-Mullerian hormone evaluation at the completion of treatment. Final and probably most important point, again, already stressed several times, the need to create a network with fertility specialists to create the oncofertility unit, which is just a network between oncologists and fertility specialists inside your institution, if you have them, otherwise outside your institution, because this is very important to refer in a timely manner patient interest in fertility preservation, not to lose time between the oncofertility counseling and the time they access fertility preservation option. But this network is also very important for managing a lot of other gynecological related issues that our young women with breast cancer may have. For example, contraception following pregnancy after disease, all the gynecological related side effects of anti-cancer therapies, for example, ovarian function suppression as adjuvant endocrine therapy, hot flashes, sexual dysfunction. Having this network may help to improve the care of our young patients with breast cancer, have colleagues more experienced than us to discuss also these other very important side effects. And with that, I wish to thank you again for your attention and for listening to my presentation.
Hello, everybody. My name is Jose Volders. I'm a surgical oncologist from the Netherlands, working in the Diakonessenhuis in Utrecht, and I'm also the representative of the Educational and Training Committee from the ESSO, the Breast Working Group. I would like to talk to you about some scientific highlights from 2024, and it was really hard to make a selection because also in surgical oncology there has been a lot of publications. I chose 3 subjects. First, the sentinel lymph node biopsy, DCIS, and chest wall irradiation from surgical perspective. And I know we talk about de-escalation a lot, and I think it's important to talk about it. And also in these 3 subjects, we're going to talk about doing less surgery, and maybe less is more for the patients. So let's start with the sentinel lymph node biopsy. And we need to go back, starting from the radical mastectomy from Halsted, and we know that survival in that time wasn't really good, despite doing very large surgery. We also all know from the NSABP4 trial, which learned us a lot about clinical relevant nodes, and especially about the biology of those nodes. We go back to that trial because this is the base for the rest of the talk about the sentinel lymph node biopsy. What they did was they randomized radical mastectomy with mastectomy and radiotherapy and mastectomy only. So only the first group got axillary lymph node dissection. And from that group, we know that 40% had a positive lymph node. Looking at the other group, especially the mastectomy group, in theoretical, we left 40% of the positive lymph nodes behind by not performing axillary lymph node dissection. However, we saw that only in 80.6% of those patients developed positive ipsilateral nodes. So a part of the positive lymph nodes didn't have clinical consequences. What you see then in the survival was that there was no difference between group. There was a difference between local or regional recurrence, with most recurrence in the group performing only mastectomy. However, you see that it's below 15% in 25 years, and it's not 40%, what you might expect because you left 40% of the positive lymph nodes behind. And it's important to say that in this era, there wasn't systemic therapy. So this is a trial we can never repeat because in these days we give all the patients systemic therapy. But this learned us a lot about surgery only and about the biological behavior of positive lymph nodes. Then the sentinel lymph node was developed, and we all know about the Z11. And we learned also from the Z11 about the biological behavior of positive sentinel lymph nodes, because we learned that not all positive lymph nodes get clinically relevant. However, it must be said this was in the era where we did give a lot of systemic therapy to patients. So another perspective. Looking at the Z11, we saw that 27% of the positive lymph nodes, 27% of the patients who received axillary lymph node dissection for positive sentinel node had the positive nodes, so 27%. So you would expect in the group where you didn't perform axillary lymph node dissection, you left 27% of the lymph nodes positive behind. Looking at the local regional recurrence and survival, there was no difference in this group. And you can say a lot about the radiotherapy and the systemic therapy, but this is what really is important. No survival difference, no local recurrence difference between the groups. So this made us think about what's the value of doing a sentinel lymph node in low-risk breast cancer? Is it clinically relevant? So there were 4 randomized trials the past years to investigate what will happen if you omit sentinel lymph node, and looked at survival, local recurrence, and also quality of life. And the first I would like to discuss is the SOUND trial. The second is the INSEMA trial, because we have the results of these 2 studies. And the other 2, so the Nautilus and the BOOG 2013-08, the results are expected. So looking at the SOUND trial, which was published in September 2023, they looked at almost 1,500 women with clinically T1 tumors, and all the patients should have a negative ultrasound before surgery. Median age was 60, and it was a European study from 4 countries and 18 hospitals, and they randomized patients between sentinel node biopsy and no sentinel lymph node biopsy. The primary outcome was distant disease-free survival, and then they saw there was no difference in distant disease-free survival. But let's look at the group, because we're talking about elderly breast cancer patients, most of the patients being postmenopausal with ductal carcinoma, and most of the patients had a pathological T1 tumor. Some patients had postoperatively did have a T2 tumor, but those numbers are small, 4 to 5%. They were mostly grade 1-2, hormonal receptor positive, Ki67 low, and HER2 negative. So it's the low risk patient group. And when you look at the adjuvant therapies, data from the current trial indicated that adjuvant treatments were not significantly different in the 2 study groups, regardless of whether pathological information from sentinel lymph node biopsy was available. And I think these data confirm the increasing pattern of guiding adjuvant treatment, mostly through the use of biological parameters rather than clinical pathological variables. A lot of patients here received hormonal therapy, over 90%, and chemotherapy was 20%, and most of the patients received radiotherapy because there was breast conserving surgery, of course. Looking at positive axillary lymph node in the group who did underwent sentinel lymph node biopsy was 13%, 13.7, and 8.6 with macrometastasis, and 4 had 4 or more positive lymph nodes, and the follow-up was 5.7 years. And then looking at the distant-free survival, disease-free survival, and overall survival, no difference between groups. What's, of course, very interesting is the axillary recurrence. Looking at the sentinel lymph node biopsy, you see that 0.4% had axillary recurrence versus 0.7%. So no difference in local regional recurrence between these groups. So the cumulative incidence of lymph node recurrence in the axilla was very low, despite we know probably you left a 13.7%, around 30.7% nodal positive disease behind in the patients in which you did not perform sentinel lymph node biopsy. So patients with these features can be safely spared axillary surgery whenever the lack of pathological information about the lymph node does not affect the post-operative treatment plan. I think it's a very large multi-center randomized design, well defined. It supports the less invasive treatment, and also I think an important thing we need to take into account is the use of the ultrasonography to select those clinically node-negative patients. Limitations are the shorter follow-up, especially in the ER-positive tumors. We know that after 10 to 25 years, there still can be local regional recurrence and still influence on survival. And it focuses on ER-positive tumors, this limits the applicability to other subtypes. And most of the patients received adjuvant hormonal therapy. And for example, in the Netherlands, in low-risk ER-positive tumors, that's not the standard. So this could have had influence on regional recurrence. But when you look at other data, you know, this factor might be 2. So still then you have no more than 2% regional recurrence. So still recurrence rate is low in this group. Then we look at the INSEMA trial. It was published in the New England Journal of Medicine this year, past year actually, 2024. The study population looks the same, except for that they did include T2 tumors. They randomized over 5,000 patients and evaluated the oncological safety of omitting sentinel lymph node biopsy, and also looked at the quality of life. Patient group selection is actually the same. Moreover, elderly women, postmenopausal. A few of the patients did have a T2 tumor, clinically 10% and pathological 20%. And looking at the lymph node status also in this group, in the patients who did receive sentinel lymph node biopsy, around 15% had a positive lymph node. Most of the patients were hormonal positive, HER2 negative, and graded tumor was 1 or 2 with a low Ki-67 index. Also, in this study, there was no difference in invasive disease-free survival rate, and it was around 91%. It's important to say that in this patient, all patients got whole breast radiotherapy compared to the sound, in which it was 2%, and there was no difference in overall survival rates. Then looking at the local regional recurrence versus primary outcome event, so local regional relapse was 1.9 versus 1.4%, and the axillary recurrence was in the group where sentinel lymph node was not performed, 1%. It's a little bit more than the 0.3 in the other group, but still keep in mind that you left residual disease probably in the lymph node in about 15%. The safety analysis, of course, in the surgery omission group, there was less lymphedema, greater arm mobility, and less pain with involvement of the arm and shoulder because they didn't have axillary surgery. So they concluded that in this study with clinically node-negative T1 or T2 invasive breast cancer, with the nuance that they had 80% pathological T1 cancer, omission of surgical axillary staging was non-inferior to sentinel lymph node biopsy after 6 years. So they really describe it carefully, because you could say, let's start omitting in a selection of patients, in the low-risk patient. And of course, you can say something about adjuvant therapy, radiotherapy, but there is really proof that in some patients, sentinel lymph node biopsy has no clinical consequences, and you have the advantage of improved quality of life. But you cannot start omitting as a surgeon. You need to do this with your whole team, and you really make good rules with each other and talk to each other about what if the tumor is not a T1, if you decide to do only T1, but it is a T2, and what will the oncologist say if you do not have axillary staging in these patients? So you can start omitting, I'm convinced of that, but do it as a team and make really good, talk really good to each other about the what if scenarios. So the strength of this study is, again, large sample size. It's a well-designed study, and it really demonstrates safety of omitting sentinel lymph node biopsy. Limitations is, again, the longer follow-up. We don't know anything about the adjuvant therapy, so how many patients received hormonal therapy, chemotherapy. I think that would be interesting to have those outcomes also. Does doing a sentinel lymph node biopsy influence this, and what is the role of these adjuvant therapies in the outcomes? The study focused mainly on tumors below 5, but actually below 2 centimeters, because the T2 group is very low. Then there is the Choose Wisely. It's from the SSO. They already defined a couple of group of patients in which to omit sentinel lymph node biopsy based on these studies in elderly patients, where you see that the nodal recurrence rate is very low, even after 13 years in this group. And they made this schedule about patients over 60 with hormonal receptor positive tumors to omit sentinel lymph node biopsy. As I said, we're waiting for the outcomes of the Nautilus trial, which is also a randomized controlled trial with over 1,700 patients looking at the omission of sentinel lymph node. It's a Korean study. And of course, we have the both 2013-08 trial in the Netherlands with over 1,600 patients randomized after breast conserving surgery. And I think we're really awaiting this trial, because in the Netherlands, we are not used to giving all these patients adjuvant hormonal therapy. So it's very interesting to have these data. What they already did is looking at the radiotherapy in this group. So they performed a quality assurance. And what they saw is in only 1.5% of the patients, level 1 in the axilla received over 80% of radiotherapy. And this was comparable in the group. So you could say whatever comes out of the study, there was no difference in radiotherapy, and it did not influence the outcomes of the regional recurrence. And those doses were comparable with the INSEMA trial. So that's about de-escalation for a sentinel lymph node biopsy. I would like to say something about the DCIS, because this study, the COMET randomized controlled trial, was published in December, so a couple months ago. And also there was a presentation at San Antonio, and it's very interesting because we're trying to do less in low-grade DCIS. So it was a study who compared low-grade DCIS to follow-up Origis guideline surgery and radiotherapy, prospective randomized non-inferiority trial with women aged 40 years or older, hormone receptor grade 1, grade 2 tumors. So tumors DCIS. And they included from 2017 to 2021. So the interventions were active monitoring, which meant follow-up every 6 months for more than 400 patients and guideline concordant care, so surgery with or without radiation therapy. And the primary outcome to discuss now is the 2-year cumulative risk of ipsilateral invasive cancer diagnosis with a median follow-up of 37 months. And here you see the diagnosis by treatment group. So there is no difference between group, and the 2-year cumulative rate of invasive cancer was 5.9 in the guideline concordant care, so the patient who did receive surgery, and 4.2 for active monitoring. And what is interesting in this study is that 44% of the patients of the guideline care group, so they should have received surgery, were electing to decline surgery, and 40% of the active monitoring group declining monitoring. And that's exactly the reason why the LORD trial, the Dutch LORD trial, who actually also had a study on low-grade DCIS, made it a patient preference study, because these days patients want to have a decision of their own about what to do with the DCIS in their breast. Here you see that also in this patient, a lot of patients received endocrine therapy for their DCIS. And we in the Netherlands, we're not used to this, and I know other countries, it's a standard. So this must be taken into account. We're still waiting for the longer follow-up. So these are only the first results, which are very promising, but we need to wait for longer follow-up. And we're also awaiting other trials, such as the LORD, the LORETA, and the LORIS. But no, first results are very promising. And there's a third subject I want to talk to you about, very short, because it's about radiation. And then you would say, well, this was the surgical oncology presentation, but I think this is interesting news for us as surgical oncologists, because we're doing the breast reconstruction in patients, and we know that when there's radiation therapy, you can have more complication, morbidity, and sometimes we make other decisions in performing a mastectomy. So that's why I think this is still a subject for surgical oncology, but this is with the surgical perspective. I got the sheets from Ian Conkler, so thank you for that. He presented this as San Antonio this year, the 10-year results of the Supremo trial. So the Supremo trial included patients who had a mastectomy with PT1N0, PT2-1N0, or PT3, or if PT2-1-0 with grade 3 or lymphovascular invasion. What they did was randomize patients with and without chest wall irradiation, about 800 patients. And it's good to say that in 65% of the patients were node negative or had only one involved lymph node. So local recurrence, you see on the left side, you really need to look with a loop. That's what's going to the right side. That there's a really small difference between no chest wall irradiation and chest wall irradiation regarding local recurrence, because this difference is not clinically relevant. Looking at metastatic and disease-free survival, no differences. So they concluded that in patients with 1 to 3 positive nodes or negative node with other risk factors, adjuvant chest wall irradiation with optimal systemic therapy does not improve 10-year overall survival, results in a clinically insignificant reduction in chest wall recurrence, and has no impact on disease-free or metastatic survival. And therefore, they conclude that adjuvant chest wall irradiation should be omitted in most patients meeting the Supremo criteria. And I think that's good news for our patients who receive mastectomy, because I think this will mean, first of all, might do more reconstructive surgery. And second of all, in the patients of which we do reconstructive surgery, might really have advantage of not giving radiotherapy on the reconstructed breast. So these were the 3 subjects I wanted to talk to you about. So de-escalating central lymph node low risk cancer, DCIS, radiotherapy of the chest. And I didn't have time to discuss about all the studies who are de-escalating axillary surgery in the neoadjuvant setting. So looking at 2025. Of course, there will be a lot of studies about systemic therapies, but as a surgeon, we need to consider right-sizing surgery. So doing less in some patients. For example, the sentinel lymph node biopsy, we're awaiting the BOOG results. The LARGE study, we're also waiting for those results in a low-risk DCIS. And this was an interesting study from Kuhn et al. At San Antonio about axillary surgery after neoadjuvant chemotherapy in patients with isolated or micrometastatic disease in the lymph nodes. Also concluding that we could de-escalate in these patients. But there might be something more for us to do as a surgeon in patients with oligometastatic disease, especially if the systemic disease is that good. Maybe those metastatic disease not responding to treatment will come to the surgeon. And also there was an interesting talk from Labertini et al. At San Antonio about the risk-reducing mastectomy in patients with BRCA1 gene mutation. So this is what we expect from the future. This is what we learned from 2024. Thank you for the opportunity to talk to you.
Hello and welcome. It is my pleasure to discuss with you the central nervous system metastases from breast cancer for this OncoAlert colloquium. My name is Fatima Cardoso. I'm a medical oncologist, expert in breast cancer, and also president of the Advanced Breast Cancer Global Alliance, the Advanced Breast Cancer Consensus Guidelines based in Lisbon, Portugal. These are my disclosures. And what I'm going to discuss with you today has been extensively discussed in one of the latest ABC Guidelines Consensus Conference, and we even dedicated a webinar to go through the data or the little data that we have for the treatment of leptomeningeal disease, a very serious and poor prognosis clinical situation. So I advise you, those of you who have special interest, to read in detail the ABC 6 and 7 guidelines that were recently published in the breast. Let's start with the incidence or the prevalence of brain metastases. This was a very interesting and important study with 18,000 real-world patients that was presented at San Antonio 2023. And what you can see is that the cumulative incidence of brain metastases at 5 years was 23% for HER2-positive, ER-positive, 34% for HER2-positive, ER-negative, 22% for triple-negative, and 10% for ER-positive, HER2-negative subtypes. So we usually link brain metastases to HER2-positive and triple-negative disease, but it may also occur in ER-positive, HER2-negative. Now, about the issue of brain imaging, should we actively look for brain metastases? Should we perform brain imaging in asymptomatic patients trying to screen for brain metastases? And because of the advances that we had regarding brain metastasis treatment, we revoted this consensus statement at ABC 7, and you can see that 85% of the panel members still consider we should not do this. And this is because we do not have any data showing that we change in any way the outcome by detecting the brain metastases earlier. And usually when you have substantial disease in the brain, you do have symptoms. However, I call the attention that we should have a low threshold for imaging when it concerns symptoms, because the symptoms may be actually quite subtle, and we have to pay attention to any type of symptom, particularly in HER2-positive and triple-negative advanced breast cancer. For the management of brain metastases, multidisciplinarity is crucial, and it's one of the best examples where multidisciplinary care can make a difference in advanced or metastatic breast cancer. local treatment is still key and fundamental in the treatment of this type of metastasis. We should go for surgery if possible, technically feasible, and usually in situations of a single lesion. In these cases, it is also recommended, because of improved outcomes, to perform stereotactic radiotherapy to the tumor bed after surgery. And if surgery is not possible, our preferred choice is stereotactic radiation or stereotactic radiosurgery, or SRS as we call it. And we should try to delay as much as possible whole brain radiation and use it only when it's unavoidable. Regarding systemic treatment, traditionally, we know that there is a lower efficacy in the central nervous system change. So questions are, when should we change systemic therapy and which drugs should we use? In the situation of HER2 positive and brain metastases, and where there are brain metastases but stable extracranial disease, and where we can go for a local treatment based on stereotactic radiation, we do not recommend changing the systemic therapy since all the extracranial disease is stable and we can treat locally the brain metastases. And if brain metastases are the only site of recurrence, and again, we can do local treatment with stereotactic radiation, the addition of chemotherapy after the local treatment has not shown to change the course of the disease, and it's not recommended. However, we do have data, albeit of a lower level of evidence, but we do have data that in these circumstances, we should restart anti-HER2 therapy, and the data we have is to restart trastuzumab if the brain metastasis occurs after trastuzumab has been stopped. A possible alternative is to use the triplet tucatinib, trastuzumab, capecitabine, although we may also want to reserve this combination when there is a progression of the disease after local treatment. What if there is a progressive disease, but brain is the predominant site of disease burden, and we have no longer option for local therapy with radiation or surgery? In this case, this triplet is what we consider the best available option, tucatinib, trastuzumab, and capecitabine. And this is based on this pivotal trial, the HER2 CLIMB, that started as a randomized phase 2, but was enlarged to become a randomized phase 3 trial comparing the triplet with the trastuzumab capecitabine. And in this case, there was a brain MRI at baseline, so actively seeking for brain metastases. And what type of brain metastases were included? This was the first study, or one of the first studies, to include what we call active brain metastases. These are either never treated or treated with local therapy but progressing after this local therapy. And from the 291 patients with brain metastases, 174 had these active brain metastases, and 117 treated and stable brain mets. In summary of the results, and focusing today exclusively on the results for brain metastases, we can see that the addition of tucatinib led to a reduction in the progression in the brain and death of about 68% in patients with brain metastases, with 1 year CNS PFS, so meaning no progression in the brain at 1 year, of 38.4% for the triplet versus 7.9% for trastuzumab capecitabine. And this is, of course, something extremely important for our patients. And you can see here that 2 years without progression in the brain was still seen for 19% of patients and 0% for trastuzumab capecitabine. What about overall survival for patients with brain metastases? We can see, and this was updated with longer follow-up, that the addition of tucatinib led to an improvement improvement of 9 months in median overall survival for all patients with brain metastases. If we want to focus on patients with active brain metastases, so we also see that the addition of tucatinib improved median overall survival by 9.6 months. So this was the data for tucatinib. In the meantime, some data started to arise regarding trastuzumab deruxtecan. First, of a meta-analysis of patients with brain metastases treated in a number of Destiny Breast trials, and then, as I will show you, with the results of Destiny Breast 12. So what we know is that deruxtecan has some activity against brain metastases from HER2-positive advanced breast cancer, both for treated and also active brain metastases, and can be considered a treatment option. So in 2024, we had the presentation of Destiny Breast 12. This was a phase 3b/4 trial. It is a single arm, so no randomization. Very importantly to know that patients had not been previously treated with tucatinib. The trial has 2 cohorts. Today we will focus exclusively on the cohort of brain metastases that included 263 patients. Very unfortunately, this trial did not allow for patients with leptomeningeal disease to be included. And also, unfortunately, the primary endpoint chosen was PFS. I believe it would have been better to have either the CNS PFS or the overall survival as primary endpoint. Now, regarding the cohort of brain metastases, we had 106 active brain metastases, 39 only with untreated, and 67 of situation where the local treatment had been used and then there was a progression, and these in the cohort of 263 patients. At this time, some of the endpoints are still immature, and 45% of patients were still receiving trastuzumab deruxtecan. So for the primary endpoint of PFS and for the cohort of brain metastases, we have here 12 months of 61.6% PFS. So quite an important, as we already know the effect of this drug, but particularly for patients with brain metastases. And you see in the table below that this was very consistent for both stable brain metastases and active brain metastases, around 60% of 12 months PFS. And more importantly, in my point of view, was the progression-free survival in the brain. So absence of progression in the brain at 12 months was also almost 60%. And again, for both stable and active brain metastases. Regarding the overall survival, it is still very immature, and we need more follow-up to ascertain the effect. But what we can see is that at this time, 12 months overall survival was about 90%. However, we have to remember that trastuzumab deruxtecan, albeit quite an effective agent, it is also an agent that has toxicity, and some of the toxicity may be potentially fatal. In this trial, we saw 6 cases of toxic deaths due to ILD pneumonitis. And although there is already knowledge about monitoring and treating this side effect, it is important to remember that it can be potentially fatal. Do we have any other options for treating brain metastases? There is an older trial called CAMILLA, a phase 3b, that has shown that T-DM1 also has some activity against active brain metastases. A problem I wanted to highlight, which we are starting to see more and more frequently in our clinical practice, because patients are able now to live longer after treatment of the use of radiation therapy to treat brain metastases, and particularly in cases of re-radiation, we can have the situation of radionecrosis. Why is this important? Because the symptoms And the images are sometimes very difficult to make the differential diagnosis with a tumor progression. What is recommended to treat this situation is high-dose steroids. And if this is not effective, there are some data regarding the use of bevacizumab. Now, a few words about leptomeningeal disease. Unfortunately, and because these patients are almost always excluded from trials, including trials that evaluate therapies for SNS disease, as I showed you with DESTINY-Breast12, there is no standard of care for this poor prognosis situation. Even more so, the multidisciplinary discussion and an in-depth discussion with patients and caregivers must take place before we decide which type of or which modality of treatment we will be able to give to the patient, or combination of modalities between local and systemic therapies, and always involving our supportive and palliative care experts. It is also fundamental to stage the extent of leptomeningeal invasion by doing a full spine imaging with an MRI with gadolinium. Now, again, local treatment is fundamental, and radiotherapy is the treatment of choice. We can do focal radiotherapy for circumscribed, particularly symptomatic lesions. And unfortunately, we have to consider whole brain radiation when there is extensive nodular or symptomatic linear leptomeningeal disease. And sometimes this leptomeningeal invasion gives increased intracranial pressure and symptomatic hydrocephalus, requiring that a shunt may be placed. For those of you who have deep interest in the management of leptomeningeal disease from solid tumors, I recommend the reading of the ANO-ESMO clinical practice guidelines. What about intrathecal therapy? I am old enough to have participated in some of the trials with intrathecal chemotherapy, and unfortunately, they have not shown a good efficacy in terms of improving overall survival, and many of them not even improving quality of life. But it is a treatment that may palliate symptoms in some cases, but we have to know and be aware that it can have significant toxicity. So because we have so few treatment options, we say it can be considered in selected cases. And also even lower evidence we have, but there is 2 small studies showing the effect of intrathecal trastuzumab for leptomeningeal disease from HER2-positive breast cancer. This table summarizes the available evidence for intrathecal chemotherapy, and you can see all of them are small studies and no major difference in the outcomes that were measured. These are the 2 small studies with 26 and 19 patients respectively from the US and France, looking into intrathecal administration of trastuzumab. So what about the systemic therapy? As for all situations, we have to take into account the breast cancer subtype and the previous treatments. And all we have are small case series, but we do have evidence of some efficacy for capecitabine monotherapy, for the triple combination of capecitabine, trastuzumab, tucatinib, and also for trastuzumab deruxtecan. This is a trial presented at ASCO 2021 from TBCRC, looking into the triple combination with tucatinib for leptomeningeal disease with a median overall survival of 10 months and a median time to progression in the brain of 7 months. And this was actually quite impressive results. So in conclusion, and what has been practice changing in 2024, management of CNS metastases, brain or leptomeningeal, must be performed by a multidisciplinary specialized team and must have our supportive and palliative care experts included. Whenever technically feasible, in my opinion, stereotactic radiation is the preferred therapy with an high efficacy and a low toxicity. And we have to, as much as possible, delay whole brain radiotherapy. We should change systemic therapy if we cannot perform any more stereotactic radiation or if we have extensive progressive extracranial disease. And the best options, as I showed you, is the triple combination capecitabine, trastuzumab, tucatinib for HER2-positive advanced breast cancer, for both treated and active brain metastases, and also with some activity for leptomeningeal disease. In 2024, we had the practice-changing DESTINY-Breast12, showing that an option is also trastuzumab deruxtecan for HER2-positive, and I would add also for HER2-low advanced breast cancer, both treated and active brain metastases, also with some activity for leptomeningeal disease. And for the HER2-negative advanced breast cancer, we have the option of capecitabine for both brain and also with some activity for leptomeningeal disease. And we have to all fight for stopping to exclude these patients from trials. Now, few notes to let you know that the Advanced Breast Cancer Global Alliance, in collaboration with BEAG and the National Clinical Trials Network with the support from BCRF, we are creating, and there are already resources there, what we call a brain mets and leptomeningeal disease hub with sources of information for both patients and healthcare providers, and to facilitate communication about this very difficult situation. And in our website, you can translate the resources in more than 100 languages. So finally, I invite you all to attend our ABC 8 conference later in November this year. Thank you very much.
Hi, I'm Ikram Yattini, Associate Professor of Radiation Oncology at the University of Florence, Italy. And thank you very much for having invited me as this OncoAlert here in review and breast radiation therapy. So these are my conflicts of interest. This year, I would like to start from the paper published on the Lancet on November 2023, but with a full discussion in the first month of 2024 on regional node radiotherapy effects. Radiotherapy improved significantly since the 80s, improving targeting, safety, and efficacy, especially in breast cancer. Been demonstrated that radiotherapy to regional lymph nodes aims to reduce recurrence and mortality. This important paper evaluated several studies in randomized trials conducted in two specific eras, pre-1980s as compared to post-1980s. It is a meta-analysis of individual patient data, comparing regional node radiotherapy as no radiotherapy, identified by the EBCTCG systematic database research, with the primary outcomes of recurrence, breast cancer mortality, non-breast cancer mortality, and all-cause mortality, including 16 trials and more than 14,000 patients. Main findings on the newer trials, 98, 2008, 12,000 patients, there's a reduce of recurrence, a reduce of breast cancer mortality, and no significant effect on non-breast cancer mortality, with reduced all-case mortality in patients receiving regional node irradiation. If you look at the 15-year breast cancer mortality reductions, these are 1.6% in regional in N0 patients, almost 3% in patients with 1 to 3 positive axillary nodes, and almost 5% for patients affected by more than 4 positive nodes after surgery. If you look at the older trials, over 2,000 patients. There's no reduction in breast cancer mortality, increased non-breast cancer mortality, and increased all-cause mortality in patients receiving regional node irradiation. So that's a very important paper that basically the interpretation is based in trials after the 80s showed a significant reduction in breast cancer and all-cause mortality, reflecting the high advancement in radiotherapy techniques. So the importance to treat regional node with radiotherapy. And in pre-1980s trials, there's an highlight of increased non-breast cancer mortality, probably related to outdated radiotherapy methods. So this is really an important meta-analysis to start 2024 in radiotherapy. On February, we published the ESTRO endorsed recommendations on integration of radiotherapy with new modern systemic therapy in breast cancer. The paper has been published on the Lancet Oncology. This is the result of a 1-year work on a Delphi-modified consensus with experts on medical oncology, radiation, clinical oncology, and clinical specialists endorsed by ESTRO to provide the multidisciplinary recommendations for optimal integration of radiotherapy and systemic therapy. The paper and the work was built on a systematic literature review on preclinical and clinical evidence through a consensus with a modified Delphi. These are the key recommendations and findings on the importance of radiotherapy reporting. It's really crucial to report parameters and toxicity in clinical trials, to report long-term data critical for new drug radiotherapy combinations, and concerning specific safety of target drug and radiotherapy. We confirm safe combinations concerning anti-HER2 therapy, trastuzumab, pertuzumab, but also immunotherapy combined with radiotherapy. Some warning related to PARP inhibitors through enhanced effectiveness of radiotherapy, CDK4/6 inhibitors in the adjuvant setting, and especially the needs for more research for new antibody-drug conjugates. Not recommendation in terms of combination concerning PI3 inhibitors and mTOR inhibitors, looking at the available data. It's really a challenge due to the heterogeneity in trial design, in dosimetric features in radiotherapy, basically the evidence of a lack of robust data for several novel therapies. So it's really important to establish rigorous standards for integration of systemic therapy with radiotherapy in the setting of clinical trials. At time of development of clinical trials investigating a drug, of course, further research is needed to optimize safety and efficacy of combination. It's really important a patient-centered discussion about the risk and benefits to obtain the best shared decision making. It's an important paper, April 2024, published on the New England Journal of Medicine in on mission axillary dissection in breast cancer with sentinel node metastasis. Is the CENOMAC trial. First author, Jana de Boniface. But it's really important also concerning radiotherapy. This is a multi-center randomized non-inferiority phase 3 trial investigating more than 2,000 patients with clinical non-negative primary breast cancer, T1 to T3, and 1 to 2 sentinel node macro metastatic status, randomized in 2 intervention groups, sentinel node biopsy only group without completion of axillary lymph node dissection, as compared to dissection group on patients that receive completion of axillary lymph node dissection. Primary endpoint, overall survival. Secondary endpoint, recurrence-free survival reported in this trial. The non-inferiority margin based on another ratio for recurrence less than 1.44. The median follow-up of the paper is 46, almost 47 months. This is the population analysis, 1,300 patients in the sentinel group as compared to 1,200 patients. These are the recurrence-free survival rates, 89.7% in the sentinel biopsy-only group, 88.7% in the dissection, completion of dissection group, with another ratio of 0.9 below the non-inferiority margin. Really important concerning radiotherapy is the radiation therapy use. That's 89.9% received in another irradiation group as compared to 88.4% received in the nodal irradiation group. So the vast majority of patients receive nodal irradiation. So the conclusion of this phase 3 trial is that the omission of completion axillary dissection is non-inferior to dissection in recurrence-free survival for patients with sentinel node macrometastasis, most of whom receive nodal radiotherapy. So it's really important to interpret data from SENOMAC trial, because this means that the majority of these patients should receive regional node irradiation regardless the overall number of positive nodes. And then I think that this is really one of the most important papers published in the 2024. First name Charlotte Coles is the Lancet Breast Cancer Commission paper published May and discussed in San Antonio Breast Cancer Symposium 2024. Really important background on breast cancer that this work group evaluates significant global disparities in prevention, detection, treatment, and survival, trying to identify gaps and to provide a roadmap to improve equity in outcomes. These are the key findings in global inequities in care, especially concerning metastatic breast cancer patients that lack access to proper care. Inequities persist across socio-economical, racial, and geographical lines. There's a specific paragraph on hidden cost of breast cancer that it's really underestimated in assessment, since breast cancer imposes substantial financial, psychological, and social burdens on patients, families, and communities. And there's a part on prevention potential, since up to 25% of breast cancer in high-income countries could be prevented by addressing modifiable risk factor, obesity, alcohol, physical inactivity, for example, and early detection initiatives in low-middle-income countries can, at the same time, significantly reduce the late-stage diagnosis. So it's really a crucial and timely paper. The work group tried to define a roadmap for change in terms of prevention, in terms of personalization, of enabling an equitable access to appropriate treatments, including integrating metastatic cancer patients into clinical research in a framework of optimal care, fostering collaboration, strengthen international partnership for equitable early detection, treatment, and modern technologies, try to identify cost and mitigate the economical and social cost for breast cancer, and families trying to engage and empower a patient-centered communication to enhance adherence and persistence and outcomes of treatments. Concerning the this is the Green Journal 2024 on June. This is a parallel work of the consensus of ESTRO on integration of radiotherapy and systemic therapy. and is focused on the essential requirements for radiotherapy to be reported in clinical trials, also investigating not radiotherapy main outcome. The methods approach is based also in this case on a modified Delphi process focused on trials combining radiotherapy and systemic therapy. The key area of investigation is quality assurance in radiotherapy and reporting guidelines in radiotherapy features, toxicity, safety, and treatment delivery. The main findings, importance of defined radiotherapy indications, dose and fractionation, planning objectives, try to find a standard of care in reporting of radiotherapy protocols in clinical trials, homogeneous collection and reporting of radiotherapy data, even when radiotherapy, especially when radiotherapy is not the primary focus of the trial. This is the base and for the optimal requirements, trying to use a predefined radiotherapy planning packs for target volume delineation, dosimetry reporting, and quality control. It's really a challenge that we are aware that there's a quite high variability in radiotherapy technique, adherence across centers, lack of robust data on radiotherapy systemic therapy combination. But it's really important to try to implement the essential radiotherapy reporting standard of care to improve trial quality and data reliability and generalization of data. Recommendations, of course, for precision radiotherapy in breast cancer trial, trying to enhance the better integration with systemic therapy. On September 2024, this is an important, crucial systematic review and meta-analysis with an emphasis on side effect and cosmesis published on the British Medical Journal on the fractionation schedule in breast cancer. The background is based on hypofractionation, that of course is the standard of care and replace conventional fractionation. This review is a comprehensive review, try to compare conventional, moderate, and ultra hypofractionation in breast cancer. Population over 20,000 patients across 35 randomized controlled trial. And the outcomes of this review: acute late side effect, cosmesis, quality of life, and outcomes. Main findings, really important to stress the concept that the moderate hypofractionation, at least moderate hypofractionation, should be standard of care for radiotherapy in breast cancer, currently totally replacing conventional fractionation. The systematic review demonstrated the moderate hypofractionation reduced radiation, dermatitis, ultra hypofractionation 5 fraction as compared to conventional. There's a further reduction in dermatitis risk. Concerning cosmetic outcomes, moderate hypofractionation is associated with better outcomes as compared to conventional fractionation, and this is not affecting the oncological outcomes since there's a similar survival and recurrence rate across the 3 approach of treatment. Especially moderate hypofractionation offer disease-free survival benefits in specific patient selection. Concerning quality of life, moderate hypofractionation improve well-being and reduce fatigue as compared to conventional fractionation, and also ultra hypofractionation demonstrated fewer functional declines in short-term follow-up. So the main conclusions, really important: moderate hypofractionation is safe and safer as compared to conventional fractionation, more convenient, and maintain equivalent oncological outcomes. Also, 5 fractions offer similar efficacy with the potential to further optimize the treatment of our patients. So hypofractionation is the standard of care for all patients that should receive every treatment for breast cancer. And finally, December 2024, San Antonio Breast Cancer Symposium, I had the pleasure to present the interim analysis of the phase 3 trial, Europa phase 3 trial. It's a phase 3 trial that compared patients aged more than 70 years old affected by luminal A, like breast cancer stage 1, randomized to receive 1-to-1 single modality radiotherapy as compared single modality endocrine therapy. This is a pre-planned interim analysis on the first 200 patients that reach the one of the two primary outcomes, the health-related quality of life at 2 years. The other primary outcome is the 5-year ipsilateral breast tumor recurrence. At the interim analysis, we present the health-related quality of life as measured by global health status at 24 months, showing that radiotherapy group has a mean change of 3 points as compared to 10 points of decline of quality of life for the single modality endocrine therapy. Even the adjusted mean differences between arms adjusted by age and global health status of geriatric assessment show significant results in favor of radiotherapy as compared to endocrine therapy. Moreover, radiotherapy group has significantly less treatment-related adverse events. There's 20% less adverse events at the interim analysis, and also severe adverse events were more common in the endocrine therapy group, justifying these results at this time point. Concerning clinical outcomes, we are aware that this is a preliminary outcome and we need, of course, longer follow-up, but there is currently no differences in terms of ipsilateral breast tumor recurrence or other oncological clinical outcomes. The conclusions of this paper is that radiotherapy preserve health-related quality of life as compared to endocrine therapy in terms of global health status at 24 months, showing a favorable safety profile with fewer severe adverse events. But of course, this is an interim analysis and we need further data on disease control and survival to confirm this encouraging data. So basically, my final slides, I would like to thank you again for this in OncoAlert for this opportunity. What has changed in clinical practice in 2024 has been really an exciting year for radiation therapy and oncology at all. Key points: regional node radiotherapy and mortality outcomes, the meta-analysis of ABCTCG that show how modern techniques demonstrate that regional node irradiation impact on survival favorably for the majority of patients that receive regional node irradiation. Integration of radiotherapy with systemic therapy, we perform an important paper that showed the main results in terms of safety of combination of radiotherapy and systemic therapy and highlights the needs for further research in a very early phase of trial development. Axillary surgery advancement, it's really important because there are several implications for radiotherapy. We are moving forward on mission of completion of axillary node dissection and even sentinel node biopsy in selected cases that, of course, has implication for an increase of use of regional node irradiation for our patients. Concerning fractionation regimens, basically, there's no need for further data that demonstrate that at least moderate hypofractionation should totally replace conventional fractionation for our patients that should receive radiotherapy for breast cancer. And finally, important, multidisciplinary trial comparing different interventions. One example is the interim analysis or in the analysis of the Europa trial, comparing single modality radiotherapy as single modality endocrine therapy for potential fragile patients as older adults with low risk of recurrence. They show an important impact in favor of radiation therapy in terms of health-related quality of life that should be considered often one of the primary endpoints of our trial. And with that, again, I would like to thank you so much for this opportunity, and we are waiting for an exciting 2025.
Dear colleagues, dear friends, dear children, first of all, many thanks for this very kind invitation to be part of your educational activity. It's really my honor. I'm going to talk about a concept which I would mention, according to Wittgenstein, the philosophist, the limit of my language is the limit of my world. I'm going to try to merge the clinics, the pathology, and the patient and society overall. I'm going to use it using the example of the TILs. Basically, trying to answer this narrative using a real patient case, wondering, does every patient actually need adjuvant immunotherapy after having received neoadjuvant chemo plus immunotherapy? Just as a note, I don't have any conflicts of interest with anything I'm going to say in the next 15 minutes. This is so crucial, this sentence. We need to develop those so that they inform the mindset of you when you are sitting in front of your patient. And my example will illustrate that just translating blindly a clinical trial to daily practice can be complicated. I have not encountered one clinician who is not frustrated about the KEYNOTE-522 regimen and all its associated toxicities for your patients. Can I present you Erin? Erin contacted me end of 2023, her husband Adam and a two beautiful children. And to be formal, everything I'm going to say here is with her permission. Erin had a mass in the breast, 2.4 centimeters. A biopsy was taken showing triple negative with medullary features and a ton of TILs. And with high PD-L1 lymph node negative. That's all you need to know. 2.1 centimeters, triple negative, high TILs, lymph node negative. She started the KEYNOTE-522 regimen because she was stage 2. The tumor vanished after a few weeks of chemo and immunotherapy. And she started to think about, do I really need 1 year of immunotherapy? Do I really need all these chemotherapy regimens? But her oncology team, and understandably to some extent, remains very reluctant to de-escalate anything. Because you had, of course, used the KEYNOTE-522 regimen to its full extent, irrespective of what is happening with your patient. And she started to wonder, a ton of TILs, what does it mean? And she started to read some old manuscripts, and she had to contact 4 pathologists to find one to read the TILs according to the guideline. And the person, the pathologist, mentioned you have 80 to 85% of TILs. Now, for those old enough, nearly 10 years ago, a bit more, the St. Gallen International Consensus reported that for those patients, which at that time we called medullary breast cancer, the standard of care was not chemotherapy. Certainly not if you're lymph node negative. Now we call them triple negative breast cancer with medullary features. So all those patients who 10 to 15 years ago didn't receive chemotherapy now receive 1 year of immunotherapy and a lot of chemotherapy. Just to illustrate that if we change the wordings as pathologists, the treatments change while the biology remains the same. And this is an important lesson. Again, the limits of my language is the limits of my world. If we don't understand what we are doing, we do crazy things. She mailed me back 6 months later, and she said, well, the MRI, right before finishing her 6-month cycle, said excellent response to therapy. Now going to the TILs. What you see is all there is, and that's important because it's based on morphology. So what the patient mentioned high TILs, 80 to 85% is this example, for example. All those small round blue cells are TILs. Every pathologist all over the world just puts his slide on a microscope, tells you in 5 seconds whether this is immune enriched or not. Here you see the tumor cells to your left. Here you see a case without any immune cell, immune desert, as we would call it. The clinical question for every subtype of breast cancer or in oncology in general, can we define the risk of recurrence of our patient? And the question I'm going to go through you is, can we define the risk of recurrence without knowing on the immune system? What do we know? We did a pooled analysis of 9 trials, the majority of them prospective retrospective analysis of phase 3 trials, 2,000 patients. And we wondered a simple question. Can TILs, so the immune system, up or downgrade stage? Because all of you determine treatments based on stage, tumor load. What do you see? The stage 1, so up to 2 centimeters, have 96% 5 years outcome with high TILs. And again, it takes a pathologist 20 seconds to read a slide and give you this information. Stage 2, 2 centimeters up to 5 centimeters, high TILs, has a better outcome than a stage 1 with low TILs. So you can up or downgrade stage according to the extent of the immune system, the TILs. And which other variable does the same in luminal breast cancer? Histological grade. And importantly, in this study, and practically in all of the studies, if you correct for TILs, histological grade is not a prognostic variable. Quite similar for HER2-positive disease. We went even further, asking what is the natural history of those patients. So we collected a set of 400 patients, more or less, in total. No chemotherapy, 5 years follow-up, 98% outcome if you have high TILs. Okay, we went even further. We asked the natural history of those patients who are considered always to be high risk, namely the very young ones, younger than 40 years old. And partnering with the Netherlands Cancer Institute, we selected a patient set of 400 to 500 patients, asked exactly the same question. No chemotherapy, high TILs. What is the outcome? To make a long story short, if you have a very high TILs, the risk of recurrence at 15 years follow-up, if you do nothing, except surgery, of course, is 2%. Remember, our patient Erin had 85% of TILs. And now she gets 1 year of immunotherapy and 6 months of very toxic chemotherapy. And we went even further because the academic community, again, translating this notion of a clinical trial towards daily practice, we are very skeptical and demanding for things that come from ourselves. We are much less critical for biomarkers stemming from industry-driven studies for a variety of reasons, good ones and bad ones. So they told us, yes, Roberto, but this pooled analysis in Netherlands is because you are biased, you already selected patients who already do very good in the Netherlands are hyper-progressive, etc. It will not be extrapolated to other parts of the world. So we conducted a study, patients from Japan, South Korea, Europe, and the US. 2,000 patients without chemotherapy. We did find exactly the same thing. Early stage, high TILs. You do excellent if you do nothing. No chemotherapy. Now, this is important because we are not saying that you should not give chemotherapy or immunotherapy. The only thing we are saying, this is informative for you to discuss with your patient. And to illustrate the complexities of this narrative, the limits of my world is the limit of my language. In stage 2 and stage 1 is a continuum of risk of recurrence. In stage 2, we use the Keynote 522 scheme. And we do know from results presented last year that if you have a PCR, the added value of pembro is very limited to non-existing. Should these patients receive 6 months additional immunotherapy? And we do know from other studies that if you have high TILs at baseline and a PCR, you have nearly 100% 5 years outcome without any post-adjuvant immunotherapy. And again, are we saying that this patient should not receive 1 year immunotherapy? No, I'm saying this can be very informative to you. So to all of you, what would you do if you would have known on the TILs in these patients beforehand? Would you still give 1 year of immunotherapy? Let me know in the discussion. And talking to clinicians, you always say that you need prospective randomized data, Roberto, before we even consider it. Okay, that's fine. Let's see how consistent we are with this statement. How many prognostic factors we use in our daily practice for decades have the highest level of evidence? All of them, none, or just one? The answer is just one. Which one? Grade? No. Ki-67? No. Lymphovascular tumor invasion? No. Mitotic activity? No. These are 4 variables in the report of every pathologist worldwide. It's not based on the highest level of evidence. Gene expression profiles. It's the only prognostic variable tested in a prospective study. Which one? Just 2. MammaPrint Oncotype. So not EndoPredict, not Procinia, not Breast Cancer Index, not all those other ones. And I do know that many of you have already used Procinia, have already used EndoPredict in your daily practice. It doesn't have the highest level of evidence. And yet you use it. And again, this notion of we are very critical for things coming from the community and less critical for things where there is an industry partner involved. Let's go back to our patient. She mailed me back in August. And she said the tumor vanished. A complete PCR. Nothing left, nothing. So she went to a clinician. She said, well, do I really need 1 year of immunotherapy? Do I really need 6 months additional immunotherapy? And the clinicians, all of them, and she went to several ones, she said, well, why should you stop? Because you are doing excellent. You are handling the treatment well, was literally the wording. And I'm going to quote what she interpreted as handling it well. Loss of thyroid function, fatigue, dehydration, confusion, nausea, explosive diarrhea, severe stress, sleep disruption, night sweats, hair loss, scalp tenderness, bone pain, joint pain, muscle pain, inability to drive due to brain fog, loss of high-level reasoning, etc., etc. She was doing excellent according to the clinician. She was suffering. And the patient advocates at this educational activity will recognize this. What would you propose to this patient, knowing everything I told you so far? Erin decided, which I think is a heroic decision, to stop her treatment. This is not based on the decision of the clinicians. This is not based on the decision of her treating team. This is based on her own education. In conclusion, can you define the risk of recurrence of patients without knowing on the TILs in triple negative? And this is pretty much the same in HER2 positive and pretty much the same as you will see this year in high-risk luminal disease. I don't think so. Let's debate, but I don't think so. Is Erin clinically high risk? No, I don't think so. Despite being triple negative. Are all patients with triple negative breast cancer by default clinically high risk? No, I don't think so. Do all patients with triple negative breast cancer need neoadjuvant immunotherapy? I don't think so. Do all patients with triple negative breast cancer need adjuvant immunotherapy? I don't think so either. Let's debate. Erin's final say, and almost done. I'm not going to mention every single word she mentioned, but look at the 3rd paragraph. She had variables that portended a very good outcome. A very good outcome. But this was not appreciated by her clinicians. And I think, honestly, because we're not used to use prognostic variable in triple negative breast cancer, because we consider all of them as high risk. And we don't care about variables that say otherwise, because we're not used to it. And importantly, with her last paragraph, no one seemed interested in saving her from the harms, and she had serious harms of overtreatment. And once again, the notion is you need to get informed and you decide with your patient how far you go. And the TILs can help you in make this decision. And some patients opt to go for the full monthly, but others may not for a variety of reasons. So reporting the TILs would be simple. It's a simple method. It takes a few minutes of your pathologist who just needs a slide. So ask your pathologist, put it in the report as an informative nature to you. And how you use it, that's up to you, together with your patient. Everything I mentioned was, of course, with the permission of Erin, and it's reported in this manuscript that we published last year in JCO. I strongly recommend you to read it. Finally, as I said, we are excellent in producing academic output, but we are not so good in changing clinical practice. We need to do more to translate the trial findings and the translational evidence into a daily practice framework and narrative that is really helping our patient. And blindly translating a trial into a daily practice setting is not helping our patients. Maybe helping the shareholders of industry, but it's not always helping our patient. And once again, I have not encountered one single oncologist who is not frustrated with the Keynote 52 regimen. And I see the same thing happening in lung cancer, where exactly the same narrative is being debated at this moment as we speak. For those among you who want to learn about the TILs, please go visit the website. Please train yourself using a freely available course on TILs developed together with the FDA. You will get CME credits. A last word of thanks to Erin. Once again, with her permission, her story is public. And thank you all for your attention, your kindness, and your willingness to listen. Once again, probably to those bloody TILs. Thank you very much.
Hello, my name is Christine Hodgson. I'm a metastatic breast cancer patient and advocate and the co-founder of GRASP. I'm just going to talk today about some of the trials and results that came out of the San Antonio Breast Cancer Symposium that were exciting to me. The first is EMBER-3. Dr. Kamal Jabari presented results from this study, which was looking at a novel SERD called imlunestrant, hopefully I'm pronouncing that correctly, for ER-positive metastatic breast cancer patients that have progressed on a CDK inhibitor like Ibrance, Kisqali, or Verzenio. We know that CDK and endocrine therapy resistance is a major obstacle for patients living with this subtype, so we need more novel combinations of effective therapies to address this unmet need. The only approved novel SERD to date is elacestrant, and that is for ER-positive breast cancers that have an ESR1 mutation. And to be honest, the results were pretty similar for EMBER-3. However, the notable difference was that when a CDK inhibitor was added in combination with imlunestrant, as you see in that red box, all patients, regardless of ESR1 status, benefited with a 9.4-month median progression-free survival. So honestly, the trial results I'm looking forward to are those that are combine a novel SERD with a CDK inhibitor, and I want to see that all patients, regardless of ESR1 status, benefit. The next trial was PATINA, which was exciting for me because this is actually my subtype of breast cancer. PATINA was looking at triple positive metastatic breast cancer patients, and the results were presented by Dr. Otto Metzger. Patients received what typically is standard of care, Herceptin, Perjeta, and a taxane. And then if they achieved no evidence of disease, they were randomized to receive just Herceptin, Perjeta, and endocrine therapy, which is what I did in 2015. And the other experimental arm received the added CDK inhibitor. In this case, it was Ibrance. And so many of patients have actually been asking this question. I'm in many triple positive groups that say, I also have ER-positive disease with a CDK inhibitor actually help? And the answers from this trial show us that, yeah, it probably is going to help. You can see that the patients with the added CDK inhibitor in red had a 44.3-month progression-free survival. That's just over 3.5 years, which is an incredible number. As I mentioned, the drug tested with Ibrance, but this opens the door for examining whether other CDK inhibitors currently approved would have the same benefit of overcoming HER2 and endocrine therapy resistance. Also, a manageable toxicity profile is reported, although I'm very skeptical. We know that patients often underreport side effects, especially if there's concern of being removed from a trial. I myself had to drop one of the drugs from this regimen because of the side effects, so I'll be really interested to see how this regimen fares in a real-world setting. Next, I want to talk about some exciting phase 3 trials for metastatic triple-negative breast cancer. There wasn't a ton of earth-shattering news at SABCS, but that's not to say there's a lot of research and trials underway. So many of these drugs that are being studied have actually already been approved for hormone receptor positive metastatic patients. Dato-DXd was just approved on January 17th for patients with hormone receptor positive MBC. That was based on the results from the TROPION-Breast01 trial. So I'm really looking forward to the TROPION-Breast02, which is testing Dato-DXd in triple negative patients that do not have PD-L1 positivity. And TROPION-Breast05 is looking at combining Dato-DXd with immunotherapy for TNBC patients with PD-L1 positivity. So we're really looking forward to those results, hopefully at a future meeting. And next, I just wanted to shout out the Patient-Centered Dosing Initiative. This was an excellent talk given by Julia Malice. The founder of the Patient-Centered Dosing Initiative, or PCDI, was Ann Lozer. She passed away in 2023, and now Julia is leading this effort. But she really challenged this notion that more is better. You can see here a study of over 1,000 patients showed that 86% had experienced at least one bad treatment-related side effect, and that's an incredibly high number. And the other finding was that 83% of patients felt better upon receiving a dose reduction. So this initiative has gained a lot of momentum and visibility in the public and has even gained traction with the FDA. And Ann's hard work and now the teams is a testament to how impactful patients can be in driving meaningful change in cancer treatment. And this just underscores the importance of including patient voices in critical conversations, which is why I also wanted to commend the SABCS organizers and planning committee for having such strong representation of advocates on almost every panel. Pictured here is myself with other advocates, researchers, and oncologists that I work closely with. Other conferences should definitely take note about the advocate representation. Giving patient advocates a seat at the table adds so much value to these discussions. And thank you also to OncoAlert for recognizing the value our voices bring. Thank you so much.
Hello, and first of all, I would like to thank for the opportunity to have the chance to present here at OncoAlert, such an important international event, that I have the chance to present the patient perspective on early breast cancer. I have to say that I picked my few personal highlights for the past year. And I think at this point, it's very hard to avoid the influence of immunotherapy, especially in triple-negative breast cancer. And that I have to say I'm very excited about the results from KEYNOTE-522, which showed that 5-year overall survival gained almost 5% with preoperative pembrolizumab and chemotherapy that was followed also with immunotherapy after the surgery. Of course, immunotherapy benefits only a subset of early breast cancer patients, but we have to keep in mind also immune-related toxicities and also financial toxicity. Moving on to exploratory biomarker analysis and T-cell inflammatory gene expression profile, which was showed in the trials that is positively linked to a complete pathologic response. Yet some questions remain open, and I think that we will see more about this in the next year, especially in regarding the pembrolizumab versus chemotherapy. Well, when you get diagnosed with breast cancer and we're meeting patients on a daily basis, new patients on a daily basis, very common question is, am I getting chemo or can I avoid the chemotherapy? In the past few years, we also saw a huge advancements in this field, and I would like to point out only a few of them, especially with antibody drug conjugates, which are very new in the past years. And I picked the results from I-SPY 2.2 trial, which showed in more than 1/3 of patients with favorable cancer burden avoided traditional chemotherapy that received only Dato-DXd and surgery. And also in a shorter course, receiving Dato-DXd showed the promising results in hormone-positive HER2-negative disease. So next topic is HER2/3 DXd, HER3. Not HER2, sorry, HER3, which showed less side effects, and side effects are very important for patients. So keep this in mind. So less side effects compared to the multi-agent chemotherapy and potential future alternative to traditional chemotherapy. And of course, there are CDK4/6 inhibitors, which are almost the standard in care all around the world, almost. I'll keep this almost in my sentence. And an update on the NATALEE trial, which supports the benefit for the high-risk patients, but we need some future research, especially on circulating tumor DNA and how to guide the treatment. For the final remarks of my talk, I would like to point out that all of this excitement about the new treatments and new therapies are very, very good, and we are very supportive as a patient community regarding this. But this brings more and more challenges, especially in understanding of all of these therapies, to explain to patients what this means, what this therapy will do, how it will reduce the disease or how they will cure the disease. Also, advancements in diagnostics and new biomarkers. This brings us to the next topic, which is access or availability of genomic and genetic testing. In many countries, including EU and North America, we have access to the treatment, but we don't have access to the diagnostic tools that we need to access to the treatment. This all combines. Of course, these new treatments are very promising in bringing better quality of life. But yet again, we have to be very cautious because treatments are getting longer and combinations of the treatments are getting challenging. But with the good management and early management of side effects, the quality of life can be very good. And of course, my favorite topic is fertility preservation. And as we also heard today about this, fertility preservation with better outcomes of the treatments is very important, especially for younger patients. But still, we know that in so many countries, it's not available and it comes still out of pocket. So thank you, OncoAlert, for bringing these topics all around the world and giving us the opportunity to discuss this with the whole community.
Thank you for joining us for Day 3 of the Colloquium. We invite you to join us again tomorrow as we review the year's highlights in GI oncology with an outstanding faculty leading the discussions. Once again, our heartfelt gratitude to our partners and collaborators, and a special thank you to Roche and Pfizer for their support of the Colloquium. Thank you for joining us today, and thank you for being a part of the OncoAlert community.